Welcome to Chapter 10, Patient Assessment. So this chapter is one of the, again, most critical in your EMT education because everything we do in the field really begins with your assessment. So before we can treat a patient, we must understand really what's happening. And that starts with knowing how to gather information accurately, quickly, and consistently. So this chapter really walks us through the 5 essential steps of a patient assessment. You have your scene size up, your primary assessment, history taking, secondary assessment, and then your reassessment, okay? So whether you're responding to a trauma call or medical call, these steps really give you a structured way to approach the patient and really prioritize your care. Mastering this process is really a non-negotiable. It's gonna be the backbone of everything else we'll do as EMTs. So let's start by grounding ourselves in, again, the national standard competencies that this chapter is built on. As EMTs, we're not just memorizing steps, we're learning to apply critical thinking in real time. So this first set of competency really focuses on scene safety and management. When we arrive on scene, our first job isn't patient care, it's actually protecting ourselves and protecting others. That means assessing the scene for hazards, understanding how the environment may impact patient care, and really anticipating any risks like violence or a hazmat exposure. We also need to consider how many patients are involved and whether we'll need more assistance, right? Whether it's additional ambulances, law enforcement, firefighting, or any specialized units. If it's really not safe for us to be there, we shouldn't enter the scene, and that's definitive. So patient care can't happen if we become patients ourselves. So continue on with scene management. The standards also emphasize recognizing when you need more resources, right? And then calling for them early. So think of a motor vehicle collision where multiple cars are involved, or maybe a home with several people showing the same type of symptoms. You'll need to initiate the incident command structure or system and possibly begin a triage type scenario. Another essential part of this competency is standard precautions. Again, we must protect ourselves from infectious disease exposure through the proper use of our PPE. So that's going to be our gloves, our masks, eye protections, and sometimes gowns. So it's not just about protecting ourselves, it's about preventing the contamination of our equipment and protecting our next patient as well. These competencies really are here to remind us that being a safe and effective EMT starts before we even lay a hand on the patient. But now we're going to kind of move on, because we just talked about these, but let's go ahead and move on to more patient-focused care, okay? This next set of competencies is going to introduce the primary assessment, okay, which we're going to go into depth. But at this stage, we assess the patient's level of consciousness using our AVPU scale and really begin evaluating their ABCs, their airway, breathing, and circulation. We're identifying any life threats and really start any type of life-saving interventions on the spot, okay? So this also includes forming an initial general impression, which is going to help us determine if our patient is stable, potentially unstable, or clearly unstable. Okay? The primary assessment doesn't replace a full physical exam. It's a rapid scan to decide what actually needs to happen right now. So if the patient isn't breathing or if they're bleeding out, they appear unconscious, that is going to be our priority. So we don't wait to finish all 5 steps before we actually intervene. So this phase is specifically about speed, recognition, and overall action, okay? So continue on, focusing on actions we take once we've identified the life threat. So it's not enough to just recognize that a patient has a compromised airway or inadequate breathing. We must immediately intervene. Okay, so this might mean opening up the airway, suctioning, inserting an airway adjunct, or beginning positive pressure ventilations, or even controlling severe bleeding. Okay? It's also about integrating any treatments that preserve life right there in the field. Okay? Our actions need to be rapid, they need to be decisive and coordinated. In this stage, we are setting the tone for everything that's going to follow. Because if we miss a life-threatening problem now, it may be too late to fix it later on. This is why EMTs must be confident in their abilities to rapidly intervene during the primary assessment, okay? Because it's truly the make or break moment of your assessment. Now let's go ahead and transition. Let's go ahead and transition into history taking, okay? So a vital part of any thorough patient assessment, okay? The history gives us content to the findings from our primary assessment and helps us begin to differentiate between different medical and trauma-related issues. It really starts with the chief complaints, so that's going to be the patient's main concern, and then understanding the mechanism of injury or the nature of illness. From there, we're going to ask about associated signs and symptoms, past medical history, what medications they're on, and much, much more. We're also going to gather something called pertinent negatives and pertinent positives, right? So a pertinent negative, these are symptoms you would expect to see with like a certain condition that the patient is actually denying having, okay? Which can help rule out specific diagnoses. Think of the history as kind of like your opportunity to become a detective, right? The better your questions, the more useful your answers will be in developing a field impression and guiding your patient care. So next, we're going to move into the secondary assessment. Okay, so beginning with either a full body scan or a focused assessment, really depending on the patient's presentation and their overall level of consciousness. Okay, so if the patient is unresponsive or has significant trauma, a rapid full body scan would be appropriate to catch any type of hidden injuries. For your alert, stable patients with isolated complaints, a focused assessment might be more appropriate. Okay, and at this stage, we're systematically checking our vital signs. We're getting the respiratory rate, the pulse, blood pressure, SpO2, and we're also doing a detailed physical exam of the systems such as, respiratory system, cardiovascular, neurological, musculoskeletal. Okay, so we're not just looking for what's wrong, we're confirming what's normal too. Okay, the quality of your assessment directly affects the accuracy of your field impression. So the more methodical and attentive you are, the more effective your treatment plan will be in the end. Now we're going to continue on detailing the secondary assessment, so focusing on the techniques of the physical examination. A proper EMT physical exam includes inspection, right? So visualizing, scanning for any abnormalities. It also involves palpation, using your hands to detect pain, deformity, or any instability, and lastly, auscultation, listening to breath sounds, and sometimes bowel sounds using a stethoscope. In the respiratory system, we check for presence of and the quality of breath sounds, right? In the cardiovascular system, we're going to evaluate the strength and rhythm of pulses and may detect signs of shock. In the neurologic and musculoskeletal systems, we're looking for changes in mental status, deficits in sensation or movement, and signs of trauma or internal injury. And when we examine the entire body by anatomic region, we're going to use the mnemonic DECAP BTLS to remember what we're looking for. Because we're looking for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. Your job is to be thorough, to be systematic, and to be efficient. So missing a key finding here could lead to delayed or incorrect treatment and care of the patient. This section is going to highlight the importance of monitoring devices in our assessment process. Again, while the physical exam and history taking remain foundational, we can't overlook the value of objective data from tools like a pulse oximeter or a blood pressure monitor. The pulse ox really helps us measure the patient's oxygen saturation, and it says how well oxygen is actually being delivered to the tissues. So a drop in your SpO2 reading could be the first sign of respiratory compromise, even before the patient looks cyanotic. Your non-invasive blood pressure monitor gives us a key insight into the circulatory status and perfusion. These devices are not replacements for our clinical judgment, but they are a valuable adjunct that can validate what we observe and really help guide our decision-making process about oxygen therapy, ventilation, and the need for rapid transport. Because remember, objective measurements strengthen your field impression, okay? But it only does if you understand how to interpret them in the context of this specific patient. Now let's talk about reassessment. So a skill that's often undervalued, but absolutely critical. So a patient's condition is dynamic. Someone who was stable 10 minutes ago could deteriorate quickly. And if we're not assessing frequently, we'll miss those specific changes. So reassessment really means checking back in on the airway, the breathing, the circulation, and the patient's mental status, as well as repeating vital signs at regular intervals. Typically for unstable patients, we're gonna do it every 5 minutes. For a stable patient, every 15. We also want to reassess the effectiveness of our interventions that we've already performed. For an example, if you applied a tourniquet, has the bleeding actually stopped? Has it stayed stopped, right? If you're assisting with ventilations, is their oxygen saturations improving? Reassessment gives us a way to track trends and respond appropriately to changes in the patient's conditions, really before they become critical. So let's go ahead and really just dive into it. So the patient assessment is essentially at the heart of what we do as EMTs. It's not just one of the skills we use, it's really the foundation of every single patient encounter. Whether we're on scene with a trauma patient or a medical emergency or even just a minor complaint, we must assess before we treat. So as EMTs, we're expected to really master this process so it becomes second nature. The better our assessment, the better our overall care is going to be. That means knowing what to look for, what questions to ask, how to gather information under intense pressure, and how to organize really what we find. Every decision that follows, so what interventions we perform, whether we transport, and how quickly, depends specifically on what we learn during this assessment. So there's going to be 5 main components of the patient assessment process, okay? The first is the scene size up. This happens before we even make patient contact, and it's going to include checking for hazards, identifying the mechanism of injury, nature of illness, determining number of patients, and the need for any additional resources. Okay. Next, we're going to have the primary assessment. This is where we rapidly identify and manage life threats using our ABCs. All right, so that's the airway, breathing, circulation. The third component is going to be the history taking, which really includes finding out the chief complaint and gathering a sample history. From there, we're going to perform a secondary assessment. This is going to be where we can do a head-to-toe exam or do a focused exam depending on the patient's overall condition. And then lastly, we're going to perform reassessments. And again, this is checking in on the patient's condition and the effectiveness of our treatments. So these 5 parts gives us a structured and flexible way to care for every patient we're ever going to encounter. Now, one of the most important takeaways here is that no single sign or symptom is going to tell you the entire story, right? A patient may have chest pain, but is it cardiac? Is it respiratory? Is it musculoskeletal? Or maybe it's gastrointestinal, right? That's why we have to combine signs and symptoms, scene information, and the patient history to really form a working impression. Because you got to remember, a symptom is something the patient feels or they tell you about, like pain or nausea. A sign is something that you can observe or is measurable, like cyanosis or tachycardia. So as you gain experience, you're going to get better at connecting these dots, but it really all starts right here with mastering your basic assessment framework. You need to stay organized, be systematic, and always let your findings guide your priorities. Now let's dive into the first of those 5 components, okay? So we have the scene size up. Before we ever even touch the patient, we evaluate the environment we're about to work in, okay? This includes constantly maintaining situational awareness, paying attention to people, surroundings, and hazards from the moment we're dispatched until the call is complete. So when we pull up to the scene, we're asking ourselves, is the scene safe, right? Are there any environmental dangers, unstable structures, weather concerns, or maybe even evidence of violence? So there's also critical elements about, where should we park our rig for safety and ease of egress, right? A scene size up also includes identifying the number of patients, the mechanism of injury or nature of illness, and whether additional resources are actually needed. So remember, our safety always comes first. We're no good to our patient if we become patients ourselves. So again, to reiterate, so before anything else, we must ensure that the scene is safe. That is going to be always our top priority. Because if we get injured, we can't help anyone. Scene safety really starts before we're going to even exit the ambulance. We take in what we can from the dispatch information, from what we see through the windshield, and really what we hear on the radio. But think about traffic patterns, hazardous materials, unstable surfaces, weather conditions, anything that could actually pose a risk. On roadways, high visibility vests are mandatory. And remember that the way you enter is often the way you're going to leave. So you really need to plan your access and your egress accordingly. Okay. We must also watch for any type of secondary hazards like broken glass, leaking fluids, electricity, fire, maybe aggressive dogs, or even agitated bystanders. Safety isn't a one-time check. It's something that we monitor throughout the entire call because as I talked about, an emergency environment is very dynamic. Let's talk about environmental conditions, all right? So these can often pose a serious hazards. We have rain, ice, extreme heat, uneven terrain. So these may not seem like major concerns, but until you're actually carrying a patient on a backboard or maneuvering a gurney through a narrow hallway or a steep trail. So always ask yourselves, what risks do I face right now? And what can I do to reduce them? If you're wearing rain gear or if you're using safety equipment, offer the same protection to your patient whenever possible. And then also try not to forget about the bystanders, okay? A helpful neighbor can quickly become a second patient if they slip on debris or get too close to a dangerous scene. And also, if something feels wrong, it's best to trust your instincts, trust your gut, and back out of that situation and just wait for additional resources, okay? There are plenty of documented cases of EMTs getting hurt after overriding that inner voice, okay? So don't take any unnecessary chances. So scenes involving potential violence, these are scenes that are especially unpredictable. You really want to be alert to these indicators of trouble, such as like shouting, any type of weapons that are like in plain sight, or just tense body language by the patient or any bystanders. Situations involving gangs, intoxicated individuals, or distraught family members really can escalate quickly. So when entering a home, you really want to scan for objects that can be used as weapons, right? Sometimes it's not a firearm. It might be a kitchen knife, it could be a hammer, or even just a heavy lamp, okay? So you want to do your best to position yourself so that you're between the patient and any potential threats, okay? And really never hesitate to call for law enforcement. In some areas, police respond with EMS by default. But if they don't, and the scene gives you any type of concern, just stage at a safe distance until law enforcement comes on the scene and clears it. Because again, remember, your safety and your partner's safety always comes first, okay? You can't help a patient if you're forced to retreat mid-assessment. Now, once the scene is actually safe, we begin determining whether we're actually dealing with a trauma situation, medical, or maybe a combination of both. So your mechanism of injury, or you're going to see commonly as MOI, this refers to the physical forces that caused an injury, okay? Like a car crash, a fall from a certain height, or a stab wound. understanding the type, amount, and just the direction of force is going to help us predict what kinds of internal injuries may be present. For example, if someone fell from a ladder and landed on their feet, right, we might expect injuries to the feet and ankles, but also possible damage to the spine and pelvis from that upward energy transfer. Okay. Then we have the nature of illness, or the NOI. This is going to apply to medical calls like chest pain, shortness of breath, altered mental status. So you really want to look for environmental clues like oxygen cylinders, pill bottles, unsanitary conditions, or maybe foul smells. So talk to family, or and then you can also talk to the family or any type of bystanders, because maybe they have some insight of what actually happened, or can give you valuable information about the patient. And be careful not to jump to conclusions too early on in the call. It's fine to have a working theory, but be adaptable, okay? A trauma call might have a medical origin, like a diabetic who, crashed their car because of hypoglycemia. Or a medical call might turn traumatic, like a stroke victim who fell down a bunch of stairs. So it's very important to always stay open-minded. Next we have, let's look at more mechanism of injuries. Let's start with blunt trauma. Okay, so this is one of the most common forms of MOIs we'll actually encounter. This type of trauma actually occurs when force is actually distributed over a broad area of the body. Very common in your falls, an assault, or maybe a traffic collision. In many of these cases, the skin might look completely intact. But again, don't let that fool you, because blunt traumas can cause serious internal injuries to organs, to muscles, blood vessels. That's why the absence of bleeding does not mean the absence of injury. You have to think about the organs and the tissues beneath the surface. So if you see bruising, deformity, or the patient complains of deep pain, assume that there could be internal bleeding or organ damage until proven otherwise. Because you need to remember that internal injuries from blunt trauma can be both subtle and life-threatening, especially if it's not identified early on. Now let's look at penetrating trauma. Okay, so this is kind of the opposite of your blunt traumas. This is usually easier to identify, but it can be, again, just as dangerous. Because with penetrating injuries, the force is concentrated at a single point, right? You have a knife wound, a gunshot, or even something like a puncture from a piece of rebar or just a metal rod. These all fall under the penetrating trauma, okay? The problem here is not just the visible wound, it's what lies beneath, okay? So a small entrance wound can actually make a massive internal damage or cause extreme bleeding. So with any penetrating trauma, there's also that heightened risk of infection, particularly when foreign objects are introduced into the sterile body cavities. So always consider, you also always want to consider when you're looking at penetrating traumas, the angle, the depth, and the trajectory of that object involved, okay? And if the object is still in place, you do not want to remove it. Okay, your goal is going to be to stabilize it in place and transport. Okay, removal of an impaled object could cause uncontrollable hemorrhaging in the field, and just like it sounds, it's uncontrollable, so you're not going to have a great way to stop that bleeding. Now, when it comes to medical calls, we're going to focus on what we call, again, the nature of illness, or the NOI. So unlike the mechanism of injury, the nature of illness is often more subtle, okay? It's the internal process that's going to lead to the current condition, okay? Think about things like chest pain, respiratory distress, dizziness, altered mental status. In these specific cases, we're going to rely heavily on what the patient tells us, as well as what we observe in their environment. Is there a home oxygen unit nearby? Empty medication bottles? Is the home cluttered, unusually hot or cold or dirty? These may give us important clues, okay? It's also important to use all of your senses. Sometimes you'll smell something like alcohol, vomit, or acetone on a diabetic patient's breath. Other times, you may hear a family member mention a fall or a recent illness. So it's very important as an EMT to be observant. Don't get that tunnel vision, okay? The scene itself is often going to tell a story before the patient even has a chance to say one word. Here's something to actually watch out for. When you have multiple patients with similar signs and symptoms, okay? This should really raise a bunch of red flags for potential environmental or chemical hazards. For example, if you walk into a home where several people are complaining of a headache, dizziness, nausea, you need to think carbon monoxide poisoning right away. Okay, that's not a coincidence that everyone's having the exact same signs and symptoms. It's really a scene safety issue. You'll need to really exit and call for specialized resources immediately. And then also keep in mind that dispatch info doesn't always match what you're gonna find. You may be sent for a sick person and arrive to a patient with blunt trauma from a fall, okay? Or the call may say chest pain, but it's actually a panic attack. So the takeaway here is simple. Don't lock in too early. You need to stay flexible. Let the assessment really guide your understanding, not your assumption. Now, scene awareness and adaptability are key to protecting both your patient and your crew. Because again, this whole scene size up is important to just kind of get a quick snapshot, but it shouldn't drive your entire assessment, okay? Because again, you might be working under false pretenses. Now, understanding the mechanism of injury or the nature of illness isn't just academic, okay? It really directly influences how we prepare for and how we're gonna deliver care. So identifying the MOI really helps us anticipate the type of injuries the patient might have. Example, if you know someone who was in a rollover accident, okay, you might prepare a longboard or anticipate spinal trauma even before you see the patient. Similarly, understanding the nature of illness like a chest pain or shortness of breath, it's going to guide your specific questions, your assessment tools, and your treatment. Okay, this early information helps you decide what equipment to bring in, what resources to call for, and how quickly the patient might need to be transported. So just keep in mind that things don't always present clearly, okay? A patient with trauma might also have a medical condition. Again, maybe they passed out passed out from low glucose levels, and then they fell down, right? And then they were injured. So as we gather information, we need to stay open-minded and really adjust based on what we find, okay? And that's really the art of being an EMT and being involved in EMS. It's balancing the structured assessment with the real-world flexibility. Now, so as we move into patient contact, okay, we must always begin with what we call standard precautions, okay? This means that assuming that every patient, every scene, and every bodily fluid could potentially expose us to infection, okay? Your gloves are gonna be the bare minimum you need, and they go on before you ever make patient contact. In some situations, you're gonna need eye protection, gowns, or masks, just to protect yourself from the environment and from that patient's potential exposure risk. So think about situations involving vomiting or coughing or bleeding. If you're working around glass or fluids at a trauma scene, protective boots and eyewear are going to help reduce your chance and risk of injury. So it's not just about safety though, it's about being prepared. If you've ever been caught without your PPE mid-call, you know how disruptive and risky that can actually be, okay? So make it a habit, gear up before you step out, because once you're hands-on, it's often too late. Now let's go a little bit deeper into our standard precautions. So these are based on universal infection control principles, and this is all recommended by the Center for Disease Control, the CDC. That includes your hand hygiene, use of gloves, eye protection, masks, and safe handling of any type of contaminated equipment, okay? So we apply these universally because we don't always know who's infected, and many illnesses are communicable before symptoms even appear. So a patient with dried blood on their shirt or a small cough could still carry, hepatitis or tuberculosis. In the field, we work in really close quarters, okay? We're gonna kneel in fluids, handle sharp objects, and often have minimal control over the environment, okay? Your personal protective equipment is gonna be the barrier, okay? It's gonna be your safety net. So always bring your gear in with you and really never compromise on your protection. Your health and your family's health really depends on how these habits become second nature for you. Some risks aren't visible until you're already engaged in care. Okay, so maybe you begin treating a patient and then realize they're coughing up blood, or you find out mid-call that they actually have, HIV or tuberculosis. If your PPE isn't sufficient, you really need to pause what you're doing, regroup, and then upgrade it. Okay? There's no shame in stepping back to protect yourself. You need to follow your local protocol for any post-exposure steps. That's going to include any documentation and prophylaxis. Okay? Also remember that standard eyeglasses aren't sufficient enough for eye protection, okay? Mainly because they don't seal against any type of splash or spray. So you need to use proper eye protection designed for our job, okay? Now, in situations involving respiratory illness, the use of an N95 or a surgical mask may be appropriate, okay? And always assume that even dried fluids like blood, saliva, vomit, they can carry pathogens. Really, your bottom line for this whole section is if you're wondering whether you need to wear your PPE or a specific PPE, the answer is yes. Okay, it's far better to overprotect yourself than to be exposed because you underestimated the risk that was involved. Now, once your scene is secure, okay, and you've protected yourselves with standard precautions, your next priority is actually determining how many patients you're going to be dealing with. So at first glance, this might be pretty straightforward, but it's easy to overlook additional patients, especially in a chaotic or a crowded environment. A good rule of thumb is to scan the entire area before committing to one patient. So you want to ask bystanders or other responders if they've seen anyone else hurt or sick. This count is really vital for one big reason, right? It drives how many resources you actually need. So if you're alone with 2 critical patients, someone's care will be delayed unless more help is on the way. That's why as soon as you recognize multi-patient situation, initiate the incident command system or the ICS. This system is going to bring a structure to the scene and allows responders to function in a clearly defined role. Okay, it's going to be the key for staying organized when things get a bit overwhelming. Now, once the ICS is established, this is where triage is actually going to begin. Triage, which we're going to go into much more depth later on in the semester, is the process of sorting patients by severity, and it's really critical when the number of patients exceed your ability to treat them all at once. So the goal is to ensure that limited resources go to the people who need them most urgently, okay? For example, a patient with like a minor arm fracture may wait while you manage an airway obstruction on another patient. So the most experienced EMT on scene often handles this triage because it requires quick, high-stakes decision-making, okay? And then once triage is complete, patients are assigned to treatment and transport units, okay? So having a solid grasp of this process ensures that chaos doesn't dictate patient outcomes. Because you need to remember, triage isn't just for mass casualty incidents. It applies anytime your resources are stretched across multiple patients. So not every situation can be handled by your standard ambulance crew, okay? Some calls actually require additional or specialized resources. Maybe you need more ambulances, or maybe the patient's condition calls for ALS intervention from a paramedic unit. In the more complex incidents, you might need hazmat teams, technical rescue teams, or even air medical transport. Scenes involving water rescue, structural collapse, toxic exposure, those can easily overwhelm a BLS crew. So that's why early recognition is so essential. If you suspect you'll need more support, don't wait. Just call for those resources as early as possible. Really delaying the request can impact both your safety and your patient's outcome. So it's better to cancel unnecessary resources than to call too late and leave a patient waiting without any proper care. And now when you're trying to make this decision on whether to call for help, you just have to ask yourself 3 specific questions, right? Number 1, does the scene pose a threat to me, my partner, or anyone else? Okay. How many patients are there? Do we have the resources to handle their conditions? So if the answer to any of those questions raises any doubt, it's a time to request additional units or resources. Because remember, it's not a sign of weakness, it's a sign of professional judgment. Knowing your limits and respecting them helps protect your patients and your team. You may be highly trained, but that doesn't mean you're equipped to handle every possible scenario by yourself. So that's why this whole system actually exists, so we can bring in the right team for the right job at the right time. Now, in many cases, these specialized resources go beyond EMS, okay? So our fire departments may be called for a technical rescue or a hazmat response or extrication. You might have law enforcement needed to, control a crowd, maybe manage traffic or secure a crime scene or deal with a potentially violent individual. In the extreme cases, you might need air medical transport or a critical care team to may be required for patients with serious trauma or potentially in an isolated location. So if you ever find yourself hesitating, just remember, the sooner you identify the need, the faster that help will arrive. So knowing what your EMS system can provide and how to activate those resources is part of your role as an EMT. Safety, efficiency, and the patient outcomes depend on recognizing when something is outside your scope and getting the right help in motion early as possible. Now let's move on to our actual treatment of the patient. Okay, so we're going to start with the primary assessment. So the primary assessment is really where we shift our focus just right to that patient. Okay, it begins the moment you make eye contact and your goal is crystal clear. Okay, you want to identify and manage life threats immediately. Okay, this is not the time for detailed vitals or having an in-depth discussion on the patient's medical history. Instead, you're quickly checking for level of consciousness, their airway, their breathing, their circulation, and again, that's what we're going to call our ABCs. At each of those steps, if a life threat is found, you need to stop and correct it. So if the airway is blocked, you need to open it. If breathing is inadequate, you need to assist with ventilations. If there's uncontrolled bleeding, you need to stop it. So this is a focused, systematic scan of the body that's designed to answer the one question: can this patient survive the next few minutes without intervention? If not, then you need to intervene now. Everything else can wait. So with that in mind, your general impression, okay, so we're into the primary assessment. This is where you're gonna get your first eyes on the patient. Okay, so we're breaking down the primary assessment. Your general impression begins as you actually approach the patient. So before you say a word, you're gonna take everything you see, everything you hear, everything you smell, into account. So you're looking at their posture, so their body position. You're looking at their skin color, their breathing effort, their facial expressions, their overall level of distress, their eye tracking. You're looking at their weight, their potential age, their sex. All of these little details are going to help frame a picture of this assessment, right? You're assessing, hey, are they awake and talking? Are they slumped over? Are they gasping for air? Are they crying? Are they silent? These details are really going to help you quickly decide, is this patient stable? Are they potentially unstable? Or are they obviously unstable? And as I said, you're going to take a note of their age, their sex, their race, and the environment. Because again, they may affect what type of conditions you're actually expecting. For example, like a young woman with abdominal pain may raise your concerns about pregnancy-related complications that wouldn't apply to other demographics, okay? So this general impression really guides your entire approach. So you really need to be deliberate, be observant, and quick to act on any type of red flag. Now, as you get closer, refine your impression by, again, noting the patient's position, any obvious injuries or conditions, right? Is the patient lying still or are they moving? Are they guarding a specific area of their body? Are they responsive when you actually enter the room, or do they seem unaware of your presence? So you want to avoid towering over the patient. Instead, approach calmly and at eye level if possible. You're going to introduce yourself and ask their name and what happened. The way they respond gives you an instant insight into their airway, their breathing, their circulation, and their mental status. So if they don't answer with words, sounds like gurgling or silence can actually reveal important things about their condition. Sometimes you'll find an obvious life threat like severe bleeding or agonal respirations right away. If so, you're going to stop your assessment and act decisively, right? You never wait to treat a life-threatening condition. Now, after taking in that patient's conditions and their appearance and their positioning and initial response, it's going to be time to classify their status, right? Do they appear stable? Do they appear potentially unstable, or are they just unstable? This classification isn't permanent. It's going to be dynamic and can change within moments. So we must always be prepared to reassess. Okay, for example, like a patient may seem stable initially, but begin to deteriorate as internal bleeding progresses. So once you've made your general impression, you're ready to move into the hands-on portion of the primary assessment, starting with identifying and controlling any uncontrolled external bleeding, right? If the blood is pooling, clothing is soaked, or you see spurting from an artery, this is going to take priority over everything else, even the airway and breathing. Because remember, a massive hemorrhage can kill a patient just as fast or faster than a blocked airway. Now, at any time you encounter a patient, especially in your trauma scenarios, you need to scan for those potential uncontrolled external bleeding, okay? This step is so critical that it actually will shift ABCs into CABs, where circulation comes first. And this is going to be in cases of, patient being unconscious, or in this case, severe hemorrhage. So look for large volumes of blood spurting from the wounds, or bleeding that's soaking through clothing and pooling beneath the patient. These signs really indicate life-threatening blood loss that really has to be stopped immediately. You're going to apply direct pressure, use a tourniquet, and then and reassess often. So uncontrolled external bleeding is one of the most preventable causes of pre-hospital death. So if you see it, you need to treat it first. Don't move on to airway or breathing until it is absolutely controlled. Okay, it's always life over protocol every single time. Now, once the bleeding has been controlled, the next step in your primary assessment is really to evaluate the patient's level of consciousness, or their LOC. This is going to help really determine both the severity of the patient's condition and their ability to provide information and follow commands. So level of consciousness is really going to give us immediate insight into brain function and perfusion. Is the brain getting enough oxygen and glucose? Are there signs of neurological compromise? At this point, we're not doing a full neuro exam. We're just doing a quick assessment to identify whether the patient is alert and how they respond to external stimuli. And the simplest way that we're going to do this is using the AVPU scale. And this AVPU scale is really if a patient is unconscious, okay? Or is a way we can kind of go through the steps to determine what level of responsiveness they have. So let's kind of jump into it. But before we jump into it, let's talk about the big picture, right? So if a patient is unconscious, we know right away that there's a serious emergency, okay? They're not protecting their own airway, and they're likely dealing with a problem that's influencing and impacting their respiratory, circulatory, and probably their central nervous system as well. So this is a high priority patient, okay? On the other hand, a conscious patient with an altered mental status, whether it's confusion, agitation, disorientation, that's also going to red flags on its own. So it could be due to, hypoxia, hypoglycemia, stroke, trauma, intoxication. There's so many different causes. So when we assess level of consciousness, we're not just checking whether they're awake, we're trying to determine how aware and how functional they are, and whether that changes over time. Okay, and that's where AVPU comes in. It's really an easy, fast way to classify responsiveness during your primary assessment. So let's kind of dive into that. So to assess your patient's responsiveness, let's look at the AVPU scale, okay? This is a fast and effective tool in the field, okay? So AVPU. So AVPU stands for awake and alert. V is responsive to verbal stimuli. P is responsive to painful stimuli, and U is unresponsive, okay? So start by seeing if the patient is awake and tracking you visually, okay? Are their eyes open spontaneously? Do they respond appropriately to questions or commands? If not, you're gonna move on to the verbal stimulus. So you're gonna use a loud voice or call their name. If they don't respond to that, apply a painful stimuli, such as a trapezius pinch or a pressure to the orbital ridge or interdigital pressure, really whichever your local protocol will allow you to do. If there's still no response, then we classify them as unresponsive, okay? So you need to keep in mind that AVPU is not just about consciousness. It helps really predict how reliable the patient's answers will be during your actual assessment. So let's break it down a little bit further, and let's go through each step. So awake and alert, right? So that means the patient opens their eyes, responsive, and can follow commands. Verbal stimulus includes, talking in a normal voice and then escalating volume if needed. If they respond only when you shout, that's still considered a verbal response, okay? Your painful stimuli comes into play when the patient doesn't respond to any sound. So again, you're going to use methods like, the trapezius pinch and, maybe the sternal rub, depending if your protocol allows it. But you need to be consistent and ethical, okay? Our goal is to detect brain function, not to inflict harm, okay? Then lastly, we have unresponsive, and that just means, again, the patient shows no reaction to verbal or painful stimuli. Patients who are unresponsive, they're typically going to lack a gag reflex or a cough reflex and are unable to protect their own airway, okay? Always document what stimulus you use and how the patient responded, because this forms really a baseline for you for when you do your reassessment. Now, when applying your painful stimuli, it's really important to use the appropriate technique and location. For example, a gentle but firm pinch of the trapezius muscle or pressure to the bone above the eye is typically enough to gauge a response. Be cautious though when dealing with a trauma patient. You don't want to worsen a spinal injury or just cause unnecessary discomfort. And then note whether the patient withdraws, moans, or attempts to push your hand away. These are all signs of neurological function, okay? Also note if the response is localized, right? Like swatting your hand away, or versus a generalized like a decelerate posturing, okay? And we're gonna talk more about that when we get into the Glasgow coma scale. But the type of response is going to give you a lot of insight into how intact the patient's CNS is at that specific moment in time. So now let's go take a step further and assess orientation. Okay, so this is going to give us, beyond just whether the patient is responsiveness, we want to know how aware are they of their specific situation, right? So the 4 things we're going to check are person, place, time, and event. Okay, so these are going to be our ANO times 4 questions. Alert and oriented times 4 specific aspects. So for person, does the patient know their name? Okay. For place, do they know where they're at? For time, do they know what the day is or the year is? And then event, do they know what happened? Again, we're going to often say someone is alert and oriented times 4 if they can answer all these 4 questions correctly. This is going to help you distinguish between a patient who is, simply, sleepy and one who is showing signs of altered mental status, which could be a result of head trauma, hypoxia, hypoglycemia, stroke, a whole list of potential underlying conditions. The orientation gives you a better picture of mental status and whether it's improving, staying the same, or deteriorating over time. Now, once you've assessed orientation, you need to remember this. Any deviation from that patient's baseline mental status is considered altered mental status, or AMS. Now, that includes patients who are alert but confused, disoriented, or unable to answer basic questions about the person, place, time, or event. Some patients may live with a baseline cognitive impairment, like due to dementia or a past stroke, or maybe just developmental delay. So it's important whenever possible to determine what's really normal for that patient. This is where a family member or a caregiver can be a valuable resource. Okay? And if the patient has any of the indicators for spinal injury, such as like a trauma with altered mental status or a distracting injury, manual cervical spine stabilization must begin immediately. Okay, so this should be done before applying a cervical collar or moving the patient. You want to protect the spine. You really protect the spine the moment the red flag appears, not after confirming an injury. So now we focus on the most critical step in the primary assessment, and that's going to, again, identifying and treating immediate life threats. So depending on where you are in your assessment, you might have already done this, but these are the things that, again, if left uncorrected, will lead to death in minutes, such as airway obstruction, respiratory failure or arrest, shock, severe bleeding, cardiac arrest. Your job here is to spot these fast and intervene even faster. The order in which you assess ABCs can change based on the scenario, okay? In most cases, we start with airway, then breathing, and then circulation. But again, if the patient has a massive hemorrhage, bleeding is going to take priority. And that's when we follow the CAB, circulation first. The key takeaway is don't let protocol override your judgment, okay? Treat the most immediate threat first, even if that means jumping out of order. Now let's break it down a little bit further. So if the patient is also unconscious and unresponsive, we assume their airway might be compromised, okay? So without a patent airway, breathing can occur. Without breathing, oxygen doesn't get to the body, and without oxygen, the heart will actually stop. So that's the chain of deterioration, and it's going to happen fairly quickly. So once the heart stops, okay, brain cells begin dying within 4 to 6 minutes, and that's going to lead to irreversible damage. Okay, that's why you must act quickly. Your primary assessment is all about finding those critical threats and fixing them immediately. So if the patient isn't breathing, you begin ventilations. If they're bleeding out, you apply a tourniquet. If they're pulseless, you begin CPR. So these are really decisive moments, and your action or inaction can really mean the difference between the life and death of that specific patient. So let's kind of focus on the airway. So we're going to go through our ABCs. Let's focus on our airway. So this is your first hands-on priority for most patients. Is the airway open or is it clear? Is it obstructed? A patent airway is one where air is going to move freely into and out of the lungs without resistance. Okay, so any compromise here due to trauma, swelling, vomit, blood, or a foreign object, it really needs to be addressed immediately. A partially blocked airway might be present with what we call noisy breathing, like gurgling, snoring, or stridor, where a fully obstructed airway might be silent. Either way, you don't proceed until that airway is clear, right? So if the patient can talk clearly, the airway is likely intact. If it's not, it's your job to actually act. Position the patient, suction, or clear the actual obstruction. Failure to secure that airway at this stage will undermine all future care, okay? Oxygen can't help the patient if it's not getting into the actual lungs. Now, when it comes to your actual airway assessment, the patient's level of responsiveness is actually going to play a big role in how you, in your overall approach. A responsive patient who is talking or crying has an open airway, but you don't want to just stop there. You want to listen carefully for how they're speaking, right? Do they have a hoarse voice? Are they speaking in 1 or 2 word sentences? Do they sound like they're actually choking or gurgling? Those subtle clues can actually signal to an impending obstruction. So if the patient is unable to speak, unable to cough, or breathe effectively, again, that's going to be a major red flag, and you must intervene immediately. So remember, even in a responsive patient, vomiting or swelling can develop quickly and compromise the airway. So always be prepared to act and reassess often, because airway status, again, can change within seconds. Now, if you have a patient who is unresponsive, things are going to change a bit. An unconscious patient loses muscle tone, and that includes the muscles that hold the tongue forward. That means the tongue can easily fall back and obstruct the airway. In these situations, you're going to need to use an airway opening maneuver. If the trauma is suspected, you're going to use what's called the jaw thrust maneuver, and if no trauma is suspected, you're going to use the head tilt chin lift. These are really foundational skills that help restore a patent airway rather quickly. If positioning alone doesn't fix the obstruction, then suctioning might be required, right? Blood, vomit, teeth, foreign bodies, those are all common causes of airway compromise in the field. But once it's clear, then consider inserting a basic life support airway adjunct, such as an oropharyngeal airway, an OPA, or a nasopharyngeal airway, an MPA. This is going to help keep the airway open, and it's possible if the condition, the patient's condition allows for it. Okay. Now these interventions are going to stabilize the airway so you can continue on with your actual assessment. So let's talk about the different signs of an airway obstruction in an unconscious patient. So you're going to look and you're going to listen. If you see obvious trauma to the face or the neck, or if the patient has blood, vomitus, or any type of fluid in the mouth, that airway may already be compromised, okay? So noisy breathing like snoring, gurgling, or crowing means there's a partial blockage somewhere. If breathing is extremely shallow or absent, the airway must be opened and reassessed immediately. In any of these cases, though, stop what you're doing and address the airway first. Use suction, reposition the patient, and use adjuncts as needed. If the airway remains inadequate, you won't be able to deliver any effective ventilations, any oxygen, or any medications. So airway management is always the foundation. If the airway isn't clear, then nothing else you do will even matter. So once we know the patient is actually breathing, we now evaluate how much effort it actually takes for them to do so. So breathing should be easy and relatively quiet, right? So if you see a patient working hard just to move air, that's really a warning sign, okay? So you want to watch for what we call retractions, which are the pulling in of the skin above the clavicles and between the ribs, as well as nasal flaring, especially in children, right? These indicate the patient's actually struggling to breathe. Also pay attention to their positioning. A patient who is sitting upright, leaning forward, and bracing on their knees is likely in what we would call the tripod position. Now in pediatrics, the equivalent is the sniffing position. So the chin is forward, nose is up, suggesting airway compromise. Now these body positionings are physical compensations to really help open up the airway and to improve airflow. So when you see them, take them seriously because they are not normal breathing and they really indicate a high level of distress in the patient. Now let's clarify the difference real quick between respiratory distress and respiratory failure. Okay, so in respiratory distress, the patient is still compensating. Their breathing is labored, but they're still exchanging air, at least for the moment, right? So you'll often see an increased rate and effort, along with some accessory muscle use. Maybe some mild tachycardia or anxiety, where in contrast, respiratory failure is when the body can no longer keep up, right? The effort becomes too much or the respiratory drive just shuts down completely. So you might see bradypnea, altered mental status, or poor chest rise in these patients. Now, if failure progresses unchecked, the patient will stop breathing altogether, and that leads to respiratory arrest. Okay, so your goal is to recognize and act before it gets to that point, obviously. So don't wait until the patient stops breathing to intervene, right? So if you see signs of respiratory failure, you need to start ventilating with the bag valve mask like almost immediately. Another tool that we use to evaluate respiratory status is the patient's speech. So a patient who can speak only like 2 or 3 words at a time without pausing for air is in significant distress. Okay, so we call this 2 to 3 word dyspnea, which is like 2 to 3 or shortness of breath. It's very reliable sign for compromised breathing. Listen closely to the way they're actually talking. Also, observe chest wall motion. Are both sides rising equally? Is the movement shallow or is it exaggerated? Shallow breathing might mean low tidal volume and poor gas exchange. Okay. Then you have deep labored breaths may indicate the patient is trying hard to actually compensate. So these small details, what you see, what you hear and feel, really give you critical insight into how well your patient is ventilating. You really always want to pair your observations with the vital signs, the O2 saturations, but again, don't rely solely on the monitor. You need to trust your assessment first and utilize everything else to reconfirm what your impression is. So let's summarize really the progression. Respiratory failure, again, starts with an increased rate and effort. Patients may be anxious, tachypnic, and compensating, right? So if it goes untreated, that's when they're going to progress to the respiratory failure, where the effort completely drops off, breathing becomes inadequate, and mental status will actually decline. So finally, without intervention from that, the patient will enter respiratory arrest, where breathing was going to stop altogether. When this happens, the clock starts kind of ticking fast. Brain damage begins within minutes of oxygen deprivation. So that's why your ability to recognize and treat respiratory problems early is so vastly important. You really need to you must act the moment that breathing becomes ineffective, okay? Whether it's with oxygen, suctioning, just positioning, or with assisted ventilations, right? Your intervention can really keep your patient from crashing. So just act, right? Don't hesitate, intervene early, and then reassess frequently. So now that we've checked airway and breathing, we're going to move to the circulation portion of the primary assessment, okay? So circulation refers to how well blood is flowing to the brain, the heart, the lungs, and overall the rest of the body. So if at any point circulation is compromised, your cells will start to die, okay? And they're going to die fast. So we need to begin by checking the patient's mental status, their pulse, their skin condition. If any of these three areas are abnormal, it may signal like inadequate perfusion. So always start by looking for severe external bleeding, right? So if you see it, you need to control it immediately. Next, again, check for a pulse. Is it present? Is it absent? Is it strong, weak, fast, slow? These clues are going to give us some vital information about the patient's circulatory system and can help us determine whether shock is setting in. And then one of the first circulation signs to check, again, being that pulse. So let's go ahead and kind of talk about what actually is a pulse. So a pulse is generated by the pressure wave that travels through the arteries every time the heart actually contracts or beats, right? To feel the pulse, you use your index and middle fingers or middle and ring, but never your thumb, and then palpate at a various pulse point where a major artery is close to the surface and can be pressed against the bone, so to speak. So in a responsive adult or child, you're going to check the radial pulse at the wrist. In an unresponsive patient or just an unconscious patient, you go straight to the carotid pulse in the neck. Okay. Now for infants under 1 year old, you're going to feel for what we call the brachial pulse on the inside of the upper arm. And if you can't palpate a pulse in an unresponsive patient, you immediately begin CPR. You don't waste time searching. If you're ever in doubt, you just want to act fast and start that CPR, beginning, of course, with high quality compressions. Now, let's evaluate the actual skin, okay? So which can really tell you a lot about circulation and perfusion. Now, normal skin color, temperature, moisture is going to indicate blood is flowing well and the body is oxygenated. Poor circulation, on the other hand, is going to lead to skin that's pale white, gray, or ashen, okay? In cases of low oxygenation, the skin actually might appear blue, which we'll call cyanotic, especially around the lips, the fingertips, the mucous membranes. Now, the patient's temperature also matters, right? Normal skin should feel warm, okay? So if you have a patient who has cool or cold skin, that may actually indicate hypoperfusion, hypothermia, or just shock. And then let's go ahead and look at, you want to assess for moisture, okay? So dry skin is what we would consider normal. If you have a patient with moist, clammy, or sweaty skin, that's often a red flag for poor perfusion. So always evaluate these signs all together: color, temperature, moisture, and then document your findings in your patient care report. Now, let's dig a little deeper though into the skin color. So if in the patients with light skin tones, so changes like pallor or cyanosis are really often pretty easy to see. Now in darker skin patients, you want to look at the mucous membranes, okay? So those are going to be inside the mouth, the lips, or the lower eyelids. You can also assess the palms of the hands or the soles of the feet, especially in your children patients, but poor perfusion may cause the skin to appear gray or mottled, and in severe cases, you actually might notice a yellowish discoloration due to liver dysfunction, which we'll call jaundice. So these signs, again, are not just cosmetic. They're really reflections of the internal physiology. So if you notice any abnormal skin tone, take it seriously because it may be the first outward indicator of an internal emergency. So here again, we kind of have a picture of an infant with that cyanosis, that bluish gray coloring around the lips and the eyes. And again, this has all to do with low oxygen levels in the tissues. So now let's kind of talk about and go a little bit deeper into the skin temperature. Okay, so again, it's another valuable clue in evaluating overall perfusion. A well perfused patient will usually have the skin that kind of feels warm to the touch. And as I said, a cold or cool skin would indicate, shock, hypothermia, maybe severe blood loss. Whereas a hot skin may indicate fever, heat stroke, or an infection. You can check the temperature by using the back of your gloved hand on the patient's forehead, their chest, extremities, their abdomen. And you want to pair this with your other observations to paint a full picture, okay? You also want to take a note of their moisture level. If the patient is diaphoretic, which means they're like sweating profusely, and this has to be in the absence of exertion and the absence of extreme like heat environment. It often means the body is under immense stress internally. So these findings should immediately trigger you to really reassess their ABCs and begin treating for shock if it's indicated. Now, the last part is, again, if in the addition to the skin color and the temperature, we're also going to look a little bit deeper at the skin moisture, okay? As I stated, normally skin should be dry, right? So it should be pink, warm, and dry. But if the patient's skin is moist, clammy, excessively sweaty, that's going to be a red flag, right? And again, I talked about diaphoresis, which is a sudden heavy sweating, and that's usually because of a pain situation, stress, or shock. Now, it often appears in patients that are experiencing a cardiac event, severe internal bleeding, or some type of other life-threatening emergency. So really be sure to report and document this. It's important to note that cold, pale, and clammy skin, that is pretty much a hallmark presentation of poor perfusion, okay? Combine that with other findings like, a weak pulse, low blood pressure, it may indicate that the body is actually diverting blood to the core and away from the skin. And again, that's an early compensation sign of shock. Now, another part of circulation that is valuable in your assessment is capillary refill. Okay, so this is really helpful for our pediatric patients, typically the age of 6 and under. To perform this test, you just simply press on the patient's fingernail or their toenail until it blanches, and then you release and see how long it takes for that color to return. In a well-perfused person, color should return within about 2 seconds. If it takes longer, that's considered a delayed capillary refill, which may indicate poor peripheral circulation, maybe hypovolemia, maybe shock. So while cap refill is most accurate in our infants and young children, in adults it can also be effective by other factors like cold environments or smoking history. So use it as more of supporting evidence and not the sole indicator of perfusion. So again, in children 6 and under, or any patient with signs of circulatory compromise, delayed refill really shouldn't be ignored. And it's a imperative sign that the patient is in some type of compromise. So again, here's the technique once again. We can just kind of talk about it again. So using your thumbnail again and your forefinger, all you have to do is gently squeeze a fingernail or toenail or even an area of skin such like the forehead or a sternum on the infants. The area really should turn white, which is what we call blanche, as blood is pretty much forced out of the capillaries of the area. And then once you release that pressure, you're going to time how long it actually takes for the peak color to return. You can even use a simple mental phrase like cap refill to time the return, like it's just actually saying capillary refill, because that should happen in about the same time it takes you to say the phrase, which is about 2 seconds. Now, if it doesn't, consider what you're seeing. Like, so if it takes longer than 2 seconds, all right, does the patient have weak pulses? Do they have cool skin? Do they have altered mental status? And then start treating for shock if you have multiple signs that kind of align with that clinical diagnosis. Cap refill, again, isn't definitive, but when you pair it with other findings, it can just reinforce your impression of the patient's overall circulatory status. So now let's, again, revisit the top priority, which we talked about in the beginning, and that's external bleeding. Now, if your patient is bleeding significantly, you need to stop everything and control it. Large volume of blood loss is a life threat and really has to be addressed the here and now, even before addressing airway or breathing in some cases. So bleeding from a vein, okay, usually presents as kind of like a steady flow, whereas arterial bleeding is going to be more spurting with each heartbeat and is bright red. Both types can actually result in rapid blood loss and shock. So during your primary assessment, do a quick blood sweep. Use your gloved hand to scan the head to toe surfaces of the patient, checking for signs of bleeding. Now, if you find a serious hemorrhage, you're not going to move on to the rest of your assessment until you've actually controlled it. You're going to direct pressure. Direct pressure is going to be your first intervention, and if that fails, or if bleeding is clearly arterial, that's when you're going to apply a tourniquet high and tight on the limb. But we're going to get that more into the specifics of tourniquet application when we get later on into the trauma and bleeding chapters. Now, controlling external bleeding, again, we're going to kind of dive a little bit deeper, but again, we're going to get more practice later on. Controlling external bleeding is one of the most effective interventions you can provide in the field, right? If the bleeding isn't controlled with direct pressure, you're going to quickly escalate to a tourniquet. Now, tourniquets should be applied for obvious arterial bleeding or when the bleeding doesn't stop after a short period or a short period of firm direct pressure, okay? So you're going to place the tourniquet proximal to the wound, directly on the skin when possible, and document the time it was applied. You're going to be about 2 to 3 inches proximal to the actual wound site, never on an actual joint. And this can only be applied to a upper or lower extremity. But really, you don't want to delay. Uncontrolled bleeding can lead to hypovolemic shock within minutes. So if you're dealing with junctional areas, again, like the groin or axilla, where tourniquets are ineffective, you're going to have to use wound packing and a hemostatic gauze if it's available. And again, we're going to cover that later on. So early and aggressive control of hemorrhage can mean the difference between, again, life and death. So always include bleeding control as part of your primary assessment. Now, while bleeding is under control and your ABCs are assessed, now is the time to really perform the rapid toe exam, okay? So, but it's really only if your patient is unresponsive, unstable, or has significant trauma, okay? The exam really should only take 60 to 90 seconds, and it's really not a replacement for the full secondary assessment, okay? The purpose is really to identify life-threatening injuries that may have been missed during your initial primary assessment. So you want to look for signs of trauma like deformities, bleeding, bruising, swelling, maybe an exposed bone, okay? You're going to palpate the chest, the abdomen for, tenderness, instability, crepitus. Check for equal chest rise and fall, and expose as necessary to identify any hidden injuries. So this really is a quick systematic scan, not really a detailed physical exam, okay? And it helps you decide how fast you need to transport and what interventions are needed en route. And then let's walk through really how to perform the rapid exam step by step. You're going to begin at the head and you're going to move down, hitting on every single anatomical location. And you're going to assess for what we call DECAP BTLS. Okay, so this stands for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Again, at the neck, you're going to move down. So you're going to start at the head, then you go down to the neck. And we're going to talk about this more when we get to, again, trauma overview. And we're going to do the full-on detailed assessment. So what you're specifically looking for. But here's just a couple like tidbits, right? So at the neck, again, you're going to look for DECAP BTLS throughout the entire body. But the neck, you're looking for, jugular vein distension, tracheal deviation, medical alert tags, accessory muscles. At the chest, you expose and inspect for rise and fall of the chest, asymmetry of the chest, signs of trauma, sucking chest wounds, paradoxical chest movement. Moving down, you're going to look for distension, rigidity, guarding, ecchymosis, rebound tenderness, pulsating masses, and so on and so on and so on. So we're going to go in much more detail, but this scan is really meant to catch major problems because this one is just a quick overview. And really guide the decision about treatment and transport. So you're not getting bogged down in detail. You're just going to move with expedited purpose. So now it's time to really decide, all right, so how urgent is this patient's condition? Based on your primary assessment and the rapid scan, right, you'll determine whether the patient is high, medium, or low priority for transport. And high priority patients should be transported immediately. And those are going to be patients who are unresponsive, having difficulty breathing, experience uncontrolled bleeding, showing signs of poor perfusion, suffering from altered mental status, chest pain, complicated childbirth, in severe pain. So really in these situations, your goal is to get the patient to definitive care as soon as possible, okay? Often while continuing interventions en route, okay? Your field treatment is important, but it has limitations. If the emergency is beyond your scope or equipment, time to the hospital care becomes critical, okay? So that's kind of the situation which we're going to be at. And your treatment decision is also going to be brought in by what resources you have in the area, how far away is the most appropriate facility, what does the patient actually need for that definitive care. And then to hit a little bit more on that, so let's kind of continue on with the high priority indicators. So these aren't, and again, I know this is fairly repetitive, but the redundancy I think helps the student kind of memorize and kind of hammer home some of the key details of the chapter and all these chapters. So again, with the high priority indicators, they aren't just a checklist. They're clinical red flags, right? And they demand rapid action. So if your patient presents with altered mental status, severe chest pain, pale skin, and other signs of poor perfusion, you should immediately be thinking, hey, this patient needs to be transported now. We don't want to wait to complete every step of our assessment, right? Because we can just, some patients, you can just need to scoop them up and go, and you can continue on with your assessment in the back of the ambulance on your way to the hospital. So that really means that you just want to stabilize them, stabilize what you can, and then move, especially when the benefit of that definitive care is going to far outweigh any treatment you can provide on scene in the field. It's also important in situations like complicated childbirth or just an insane amount of severe pain. Immediate hospital access is often the most critical component here. So part of being an effective EMT is knowing when you should stay in play and when it's time to load and go. Okay, your scene time should be a reflection. It should reflect really the urgency of the patient's overall condition. Now, this brings us to one of the most important trauma care principles, right? And we're going to talk about what's called the golden hour, sometimes called the golden period, but this is really the first 60 minutes following a traumatic injury. And again, this is where timely assessment, treatment, and definitive care can make the greatest difference in a patient's survival. Now, during this time, the body, again, may still be compensating for injuries like internal bleeding, airway compromise, spinal trauma, but once decompensation begins, it can really happen fast and become irreversible. So your job is to really ensure that the patient reaches the right care within the hour. That doesn't mean spend 60 minutes on scene. It means that everything from dispatch to hospital arrival needs to happen efficiently, okay? So time is essentially tissue, especially in our trauma cases. So don't waste it on unnecessary procedures at the scene if they can be done en route to that definitive care. And again, when we're talking about this golden hour, we're emphasizing the urgency of time-sensitive interventions like surgery for internal bleeding or intubation for respiratory failure. And we're not just concerned about trauma, right? Certain medical conditions and emergencies like stroke, myocardial infarction have their own versions of this golden hour. So the sooner definitive care is delivered, the better the outcome. So as an EMT, you need to make really rapid, informed decisions. If the patient needs ALS or specialty care and your BLS, arrange for an intercept or air medical support early, right? The takeaway here really is this, don't let time slip away while you're just second guessing. You're the patient's first critical link in the chain of survival, and your speed and judgment can really change the outcome. So how do we actually decide on the transport decisions, right? So we need to consider these four main factors. What is the patient's condition? Okay, so what is the patient's condition? What's the availability of advanced care? What's the distance to the appropriate facility? And what are your local protocols, right? A stable patient with a minor injury, they may go to the nearest urgent care, okay? Well, a stroke patient may need a certified stroke center, okay? A trauma victim with multiple injuries should go to a level 1 trauma center if one is within range. And remember, like ALS versus BLS matters too. Like if a paramedic unit is available and needed, you need to request it as soon as possible. But if their ETA is longer than your ETA to the hospital and the patient is critical, you may need to transport immediately and notify the receiving facility, okay? So these are not always the black and white decisions. They really take experience, collaboration, and a solid knowledge of your system. But the goal, again, is always the same. Get the right patient to the right place at the right time. Now, once we're done with our primary, immediate life threats are addressed and all your transport decisions are made, right? That's when we're going to shift into the history taking phase of our assessment. This is really where we start to build a deeper understanding of the patient's condition, right? The key objective here is to investigate the chief complaint, and that's really the main reason that the patient or someone else called 911. Okay, this also includes just asking the patient directly if possible, and using open-ended questions to get quality information. Right. For example, like, can you tell me what you're feeling, or what made you decide to call for help today? Yeah, your goal is not only to identify the problem, but to explore how it began and how it's affecting the patients right now, okay? So what you learn here really sets the foundation for your secondary assessment and your field impression. So again, when you're investigating the chief complaint, which you're making your introductions, you make the patient feel comfortable, you obtain permission to treat. So this isn't something you're going to do necessarily after you've already done your whole primary assessment. It kind of happens during your primary assessment when you're first meeting that patient, okay? You're going to talk to that patient with respect, professionally, kind of let the patient's overall tone and kind of vibe dictate how you're going to address the patient? Do you want to use Mr., Mrs., Miss? Do you want to use, patient's last name? Let kind of their own tone and their own kind of presentation kind of dictate that. And again, you want to ask open-ended questions to allow them to actually use their own words to describe the events, describe what they're feeling. And this all takes place in the introduction concept, because we're trying to identify the chief complaint of that patient. So that's the number one thing that's actually bothering them. It's also important to obtain permission to treat, right? Because when it comes down to, in the medical field, you want to ensure that the patient is informed on everything that you're doing, okay? And that you're asking to do to them. So make sure at every step of the way, you get permission to take vital signs, you get permission to provide any type of treatment. So now if a patient themselves is alert, okay, you're going to ask questions directly, but if the patient is unresponsive or confused, in that case, you're going to gather history from, family members, friends, bystanders, or really anyone who else might know what happened. You also want to check for medical alert jewelry, prescription bottles, hospital discharge papers, because these can offer real valuable insight. So if you're in the patient's home, observe your surroundings. Are there, oxygen cylinders nearby? Are there inhalers? Evidence of drug use? Because these clues can fill in the blanks when the patient can't speak, right? EMS history taking isn't always just a formal Q&A. It's about being curious and being observant. The more information you can collect on scene, the better prepared you are to make decisions about care and about the transportation of the patient. So now, to structure your questioning, we're going to use a tool called the OPQRST. This is a mnemonic that's going to help us investigate symptoms, especially our pain or discomfort. Okay, so for O stands for onset. So what were you doing when it started? Okay, P, provocation, palliation. What makes the pain better? What makes the pain worse? Okay, so provocation would be worse, palliation would be better. Q, quality. How does it feel? Is it sharp, dull, crushing, burning? You want to really have the patient use their own words, but you can give them a bunch of adjectives if they're having trouble kind of finding the words. Then we have R, so region, radiation, recurrence. So region, where is the pain? Point to me with one finger where the most pain is. Radiation, does the pain go anywhere else on the body? And then recurrence, does the pain has it been constant or does it come and go? Then severity, on a scale of 0 to 10, 0 being no pain, 10 being the worst you've ever felt. What would you rank it as? Then timing, right? T, how long has it been going on for and has it changed? Okay, so again, this is these questions really help you pinpoint not only what the symptom is, but how serious and urgent it may be. So you won't use OPQRST on every call, but it's especially helpful for complaints like chest pain, abdominal pain, or shortness of breath. So now let's talk about another core tool in your assessment toolbox, okay? And that's the patient sample history, okay? This mnemonic helps you collect a broad but focused snapshot of your patient's background and current status. So here's what each letter actually stands for, okay? So S, signs and symptoms. A, allergies. M is for medications. P is for pertinent past medical history. L is for last oral intake. And E is for events leading up to the illness or injury, okay? You can use sample for virtually every patient you have, whether they're a medical or a trauma, conscious or altered. For example, knowing that a patient is, allergic to penicillin or that they haven't eaten 24 hours, okay? That may directly influence your treatment decisions. So try to work this into your conversation naturally. It doesn't have to be like a checklist. Use what you observe to really guide your questions. And then remember, again, the goal is to collect information that could influence patient care or just the overall hospital treatment. Now, good assessments, they aren't just about asking the right questions. It's about thinking critically as you gather and interpret information. You're not a robot just checking boxes. You're an EMS professional building a clinical picture, okay? Now, that means gathering facts through observations, questioning, listening, evaluating those facts. So, what do they mean in this specific context? And then synthesizing. So, bringing it all together to form a working field impression. Okay. So, let's say a patient reports, flu-like symptoms and a headache, and so does everyone else in the home. So, you might initially think it's like a viral illness, but critical thinking should make you wonder, could this be carbon monoxide poisoning? Okay. What about the environment suggests something bigger? Okay. That's what sets apart great EMTs, right? The ability to put the pieces together and act accordingly, not just to follow a script. Now, in that same breath, some parts of the assessment process will involve sensitive topics, okay? And it's your responsibility to approach these with, professionalism, respect, and empathy, okay? So let's start with, alcohol and drug use, okay? So patients may be kind of reluctant to disclose this due to fear of legal consequences or just shame. Okay, but substance use can significantly affect their medical condition and your overall treatment plan. So don't make assumptions, right? So instead you need to ask questions in a calm, non-judgmental way. For example, all you have to do is say, have you taken anything that could affect how you're feeling today? Or do you take any medications, prescribed or otherwise? So reassure the patient that your job is to help, not to judge, and that the information will be kept confidential as allowed by law. Another a challenging area rather, is physical abuse or violence, okay? Including domestic violence. You may suspect abuse based on inconsistent stories, injuries at different stages of healing, or just how a patient interacts with someone else on scene. So if you do suspect abuse, you're definitely not going to confront anyone directly, right? Your job is really not to investigate. Your job is to ensure patient safety and report your concerns through the proper channels. You really just have to follow your local protocols, which usually requires notifying law enforcement, child and adult protective services. So you just need to be observant, okay? Separate the patient from others when possible, and then document objectively. Include patient quotes and what you observe. Nothing about your actual opinions. Because, again, these cases may end up in court, and your report could make a difference, all right? So always remember, you're the advocate for your patient's safety. Now, the last sensitive topic area we'll cover is sexual history, okay? So this is a topic that requires, tact, compassion, and overall professionalism. These questions typically come up when a female patient of childbearing age has abdominal pain, vaginal bleeding, or maybe missed periods. So you must always consider the possibility of pregnancy. You're going to ask about their last menstrual cycle, birth control use, whether there's a chance they could be pregnant. Now, for our male patients, symptoms like painful urination, genital sores, that may require questions about sexual activity or possible sexually transmitted infections or STIs. So you really need to be respectful, use neutral language, and conduct these conversations in private whenever possible, right? So don't assume anything based on appearance or relationship status. Just ask clear, relevant questions and reassure the patient that your focus is solely on providing the best possible care. If you're uncomfortable, remember, professionalism is key, and your tone of voice, it really matters just as much as the words you decide to use. Now, not every patient will be eager or just able to talk. Some may sit silently, offering you no answers. Others may be overwhelmed, scared, or just simply unable to speak. So when you encounter silence, don't jump to conclusions. Instead, practice patience and a calm presence. You got to use gentle, close-ended questions like, "Are you in pain?" or "Can you point to me where it hurts?" Also, observe nonverbal cues, like facial expressions, body positionings, or even the patient's breathing pattern, right? So remember, like silence itself can be a symptom. It might be due to anxiety, it could be stroke, language barriers, altered level of consciousness. So don't get frustrated, just adjust your strategy, right? Silence doesn't mean there's nothing wrong. In fact, it often means the complete opposite. Now, on the flip side, some patients may be overly talkative, right? So they might actually be nervous, intoxicated, manic, or simply have a lot to say. Now, these conversations can be difficult to control, but don't dismiss them. Hidden in all that kind of chatter could be critical information. So let them speak for a moment, then gently guide the conversation really back to the chief complaint, right? You need to use redirection techniques like, "I understand, but can we go back to your chest pain for a moment?" Be mindful, of causes like stimulant use, mental illness, or anxiety. And you really want to watch for signs of, again, altered level of consciousness. The key here is for you as the provider to stay focused and respectful and to get what you need without escalating any type of tension, okay? Because again, remember, like, communication is a clinical skill, and it often takes experience and patience to actually master it. Now, some patients actually are going to present with multiple symptoms, making it really difficult to determine what's most urgent. In these cases, treat the conversation kind of like a triage process. You're going to start by identifying the most serious symptoms, what's life-threatening or immediately concerning, and work your way down. And work your way down. So ask, what is bothering you the most right now, or what started first. Take detailed notes and really don't ignore the secondary complaint, but prioritize what affects ABCs and transport decisions. Because sometimes multiple unrelated symptoms are truly happening. Other times they're all linked to the one root cause, like anxiety, infection, or substance abuse. Your job really is to clarify, prioritize, and remain organized, even if the patient is like bouncing from one issue to the next. And with that being said, let's talk about anxiety. Right. So this is a very common response in patients experiencing a medical emergency. Okay, and it can complicate your assessment. An anxious patient might have elevated heart rate and breathing, appear restless, or even report symptoms like numbness, tingling, dizziness, or chest pain. So these can actually mimic more serious conditions. So you really got to be careful when you're assessing, right? Reassure the patient, speak calmly, and create a sense of control. You want to encourage slow, steady breathing. Keep your own demeanor composed, because your emotional tone can really influence theirs. You never want to dismiss their feelings with comments like, "just calm down." Instead, you need to validate them. Yeah, you're safe now. I'm here to help. Okay. Even if the anxiety is the root cause, treat the symptoms just as serious until you rule out any more life-threatening issues. Now, occasionally you're going to encounter, and kind of, when I say occasionally, kind of like a lot, you're going to encounter anger and hostility. And it may not even be directed at you. Okay, so family members, friends, bystanders, even the patient themselves really may lash out due to stress, fear, frustration. The most important thing to remember is that these situations remember in these situations is that scene safety always comes first. So if someone is aggressive or threatening, you don't want to escalate the situation. You just got to keep a calm tone, be non-confrontational. Try to separate that angry person from the patient if it's safe to do so. Now, and if needed, involve law enforcement, okay? You're there to provide care, not to be a target, okay? Also, try your best to understand where the anger is actually coming from, because sometimes it's masking fear, grief, or trauma. So remaining calm and empathetic can really de-escalate many of these tense encounters, but really never hesitate to call for help if you ever feel unsafe. Intoxication. Now, intoxication kind of brings its own set of challenges. A patient under the influence of alcohol or drugs may be confused, belligerent, drowsy, or just completely unresponsive. The risk of violence is also higher, especially with certain substances. So you really want to protect yourself. Don't let your guard down, right? You want to approach cautiously, never alone if possible, and always remain professional. The goal is to gather whatever information you can, even if it's incomplete. So ask about what was taken, when, how much. Now, if the patient can't answer, you got to look for clues. Is there any pill bottles, paraphernalia, any witness statements? You just have to remember that intoxicated patients may have an underlying condition. They could have head trauma, hypoglycemia, that actually mimic intoxication. So don't assume it's just the alcohol. You still need to perform a full assessment and monitor the patient closely because, again, intoxication can easily mask or worsen other more serious problems. Another emotional encounter, emotional response that you're going to encounter is crying. All right, whether it's due to pain, fear, grief, just emotional overload, crying patients often need time and space to actually process. So your job is really to stay calm and be present. You want to avoid rushing them or brushing off their emotions. Your goal, you need to speak gently, offer that support, and pause your questionings if you feel like they're being overwhelmed. When they're ready, resume the assessment with a soft, supportive tone. You got to keep in mind that crying doesn't always mean a psychological distress. It could just be a signal of acute physical pain, shock, or even something like a panic attack. So your role is to be empathetic, be observant and gentle in your approach. Just as we would respond to bleeding or breathing issues with care, we should do the same for any type of emotional vulnerability. It's going to build trust, and it's often going to lead to better cooperation for the rest of the actual assessment. Now, within the same kind of the realm, let's go ahead and talk about depression. Okay, so depression is a common but kind of invisible condition that influences and impacts how patients think, feel, and communicate, right? So patients with depression, they may appear like withdrawn, hopeless, chronically fatigued. They may speak kind of in a flat, quiet tone, or even struggle to answer your basic questions. Depression is also one of the leading causes of disability worldwide and also in EMS. So we really need to be sensitive to its impact. You may even encounter patients who express suicidal thoughts, ideation, intentions. So you have to take those specifically seriously. So don't shy away from asking, like, are you thinking about hurting yourself? Do you feel safe right now? They're not invasive questions, they're life-saving questions. And you really need to document the patient's statements with using quotations, alert hospital staff, and follow your local mental health transport and crisis protocols. So sometimes just being present and listening without judgment is one of the most therapeutic things you can do for that patient with the depression. Now, moving on, some patients may actually give you information that's confusing, inconsistent, maybe just completely inaccurate. So don't immediately assume they're being uncooperative. This could be due to medical causes like hypoxia, stroke, head trauma, drug use. It could also be related to chronic conditions like, like delirium, dementia, or just some other type of psychiatric illness. So you're really, the best thing you can do is to be calm and systematic. You need to ask simple, direct questions and compare what the patient says to what you observe or what any bystanders report. It's important to use the AVPU scale and really orientation checks to assess their mental status. So if you're ever unsure whether a patient's confusion is new or baseline, just ask a family or a caregiver what's normal for them. The important takeaway really is confusing behavior may be a symptom, okay? And it should never be ignored. So keep assessing, keep observing, and just keep on gathering the clues. So now let's kind of cover limited cognitive abilities, okay? So this can make communication even more difficult, but not necessarily impossible, right? So these patients may have developmental disabilities, traumatic brain injuries, or just some type of age-related condition that influences comprehension and expression, right? So your best approach is to really keep things simple, right? Use basic language, one question at a time, and definitely avoid medical jargon, right? You want to give patient extra time to answer and don't interrupt or rush them. Watch for partial answers, gestures, or nonverbal cues. Often family members or caregivers can actually help clarify the patient's baseline function and medical history. But again, always remember to speak directly to the patient first, unless they're clearly unable or incapacitated. It's important as an EMT to respect, have patience and empathy because they go a long way. Even if communication is limited, your tone and just your body language still communicates compassion and just professionalism. So, cultural challenges can also affect every part of your assessment, from how patients describe symptoms to whether they're willing to even be touched or treated by someone of the opposite sex. So, be aware of your own biases in these situations as well, and always approach each patient as an individual. Okay, so if you encounter a language barrier or a cultural concern, respect their preferences and adapt your communication style, right? You want to use simple language, avoid idioms or slang, and if available, involve a professional interpreter or a trusted family member. But it's always, you always need to be cautious with minors translating for adults, okay? And also be mindful of nonverbal cues like eye contact or personal space, which really vary across cultures, right? A culturally competent EMT provides care that's not only medically sound, but also sensitive to beliefs, to values, and traditions, ultimately improving trust and overall patient outcomes. Language barriers, right? This is another issue that can also be fairly frustrating, but with the right approach, you can still gather critical information. You really want to start by determining whether the patient understands who you are and why you're there. You need to speak slowly, clearly, and avoid, again, complex medical terms. Use hand gestures, visual aids, or a translation app if your agency permits it. Now, if available, you always want to involve that professional interpreter, but it's not likely to be available in the field, but it will be in the clinical setting. But now, if you have a bilingual bystander or family member to assist in the moment, that would be awesome, but they're, again, not always reliable or appropriate for like confidential topics. It's also important to learn about the language diversity in your local kind of response area so you can prepare, right? You never want to assume someone is, well, let's dial back a little bit. because you can always kind of take steps to actually be prepared in those situations, whether it's like learning common phrases in those languages or carrying around some type of reference aid, like a pocketbook with like a Spanish to English translation for medical terms, that kind of certain things. Now, also hand in hand with this, you never want to assume someone is actually just straight up ignoring you. They might simply be trying to process what you're saying in a second language, okay? So really patience, effort, and a willingness to adjust will go a long way in building trust with these different patients. You can also have patients with hearing impairments, right? The key here is to be clear, be direct, and again, adaptive communications. You want to begin by facing the patient so they can see your lips and facial expressions. You want to speak slowly, speak clearly, never shout, okay? Some patients may be using like lip reading, others may use sign language, and some again may just communicate best with written notes. So if the patient uses, if the patient uses a hearing aid, just make sure it's working or ask if they want to use it. In a pinch, you can actually use a stethoscope as kind of like an improvised hearing amplifier by having the patient wear the earpieces while you speak gently into like the diaphragm. But regardless, you always want to be respectful. Don't assume the patient can understand you. Ask how they prefer to communicate. And then again, adapting your approach shows respect and can really significantly improve the quality of your overall assessment. Now, on the other side of the coin, visual impairments, right? So visual impairments can also obviously present special, unique challenges, especially when assessing orientation, gathering history, or just explaining procedures. Always identify yourself verbally when entering the scene. Don't assume that the patient can actually see your uniform. Let them know that you're there, but also what you're about to do before making physical contact. If you move any of their belongings or assist them in repositioning, you really need to return things to their original place whenever possible. Also, use descriptive language when giving instructions. Instead of like over there, say to your left or towards your feet. If you're performing a procedure like taking a blood pressure, applying oxygen, or checking pupils, really explain each step out loud. These patients rely heavily on hearing, touch, and just memory to orient themselves. So your clear step-by-step communication really helps reduce the anxiety. And again, with all these patient demographics, it's going to help build a rapport. Now, with the primary assessment, life threats, history taking complete, we're now going to move into our secondary assessment, okay? And this is your opportunity to perform a more thorough and detailed physical exam. The secondary assessment can take place on scene, in the ambulance, or sometimes not at all. It really depends on the situation itself. But the goal really is to identify hidden injuries or problems that weren't immediately obvious. Your approach largely depends on the patient's condition. If the patient is stable and has a focused complaint, you may only need to examine that specific body part or system. Whereas if the patient is unstable, unconscious, or involved in a significant trauma, you'll perform a systematic head-to-toe exam, okay? The secondary assessment also includes doing your full set of vital signs, and in many of these systems, this is where monitoring tools like pulse oximeter, blood glucose testings will be applied. Now, to conduct a thorough secondary assessment, you'll use three primary techniques: inspection, palpation, and auscultation. Inspection simply means you're going to visually scan the body for any obvious signs of injury or an illness, kind of like deformities, rashes, swelling, bruising. But then you have palpation, which involves gently feeling the body with your hands to detect tenderness, instability, crepitus, maybe some hidden bleeding. Then you have auscultation, right? So auscultation is listening to the internal sounds of the body, typically with the stethoscope, most commonly used for breath sounds, but also for bowel or heart sounds when appropriate. Really, these methods help you detect issues that the patient might not be able to describe or really even be aware of. So you always want to use like a systematic approach, head to toe for trauma, or a focused by system for a stable medical patient. And again, constantly watch the patient's face for reactions during the palpation phase, because pain on palpation really may be your first clue to a hidden injury. Now, one of the great tools that will help guide your exam, especially for our trauma patients, is going to be the DECAP BTLS mnemonic, right? So this mnemonic stands for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling, okay? Now, as you inspect and palpate each region of the body, you're going to mentally run through DECAP BTLS to make sure that you're not missing any subtle but significant findings, okay? So these clues often indicate an underlying injury, right? Like fractures, internal bleeding, or some type of soft tissue trauma. So by staying organized and methodical, you improve your odds of catching something important before it becomes life-threatening. It also helps you ensure your documentation is both thorough and supports continuity of care when handing the patient off to the nurses at the hospital. Now, a complete secondary assessment gives you time to really systematically examine the patient from head to toe, really identifying injuries that, again, might have been missed during the rapid scan. You're going to palpate the scalp and face for trauma, assess pupils for reactivity, check the chest for equal rise and fall, evaluate the abdomen for tenderness and rigidity, inspect the pelvis, the extremities, and the back. Really, each of these steps is performed in an organized, professional manner, and you're really always watching for signs of pain, instability, and just overall deterioration. So this exam should not really delay transport, okay, especially for our unstable patients. But if time and the condition allows, it gives you a comprehensive picture that's going to strengthen your field impression. So you really want to document everything you find, both positive and negative, and then reassess anything that changes during your transport. Now, in some cases, a focused assessment is going to be more appropriate than that full body exam, okay? This is typically only used when the patient is conscious, alert, and has a specific chief complaint like abdominal pain or maybe a twisted ankle. In these situations, you're going to zero in on the affected body part or the system. Like, for an example, if a patient has shortness of breath, your focused exam might include listening to breath sounds, evaluating respiratory effort, and checking the SpO2. Now, if they have chest pain, you'd focus more on the cardiovascular system, right? So the key is really just to tailor your assessment to the presenting problem. This is going to save time and it avoids unnecessary exposure or discomfort, okay? Now, that being said, you really always have to remain vigilant, right? So be ready to expand your assessment if like new symptoms are going to emerge or the patient's condition starts to deteriorate. Now, when a patient's chief complaint involves difficulty breathing, coughing, chest tightness, or maybe an abnormal lung sound, a focused assessment of the respiratory system is the primary concern and is essential. So you're going to begin by exposing the chest and looking for any asymmetry, any signs of trauma, any paradoxical movement. Now, we're going to talk about this more when we get to the trauma chapters, but we'll touch on it right now. So paradoxical chest movement is when one section of the actual chest moves opposite to the rest of it during breathing, okay? This typically will indicate a flail segment or rib fractures, okay? Now, you really want to inspect now. You want to inspect for this because it could lead to a pneumothorax or a tension pneumothorax, which would be a collapsed lung. So again, we'll cover that more in trauma. Now, also during this assessment of the respiratory system, you want to inspect for accessory muscle use, look for nasal flaring, retractions, and just observe the rate and depth of the respirations. Then you want to listen to breath sounds in multiple fields, both on the anterior and posterior aspects, and you're going to compare both sides. Any abnormal findings, it really should really immediately shift your mindset towards airway management and oxygen support. Breathing complaints are often time sensitive, so this assessment should really be quick, should be targeted, and followed by really immediate interventions and as indicated. So to begin your assessment of the respiratory system, we should really look at the patient's respiratory rate. Now, in adult patients, the normal range is between 12 to 20 breaths per minute, while children will generally breathe much faster. And we'll talk about those numbers a little bit later on when we get to the pediatrics chapter. Now, count the respirations. Now, well, for best practices, you want to count the respirations by watching the chest rise and fall for 30 seconds and then multiplying it by 2. While you do this, you also want to note the rhythm. Is it regular or is it irregular? Are the breaths deep and even, or are they shallow and erratic, right? So you're going to evaluate whether the patient is breathing too slowly or too quickly. And if their breathing pattern really matches their level of distress. For example, someone with a high respiratory rate and labored effort may be in respiratory distress, while a slow, irregular pattern may just signal fatigue or impending failure. The rate, rhythm, and quality of breathing together really help paint a full picture of just how well the respiratory system is functioning and thus perfusing the body with oxygen. Next, you want to just take a little deeper dive. Let's look at the respiratory rhythm, right? So the regularity of breathing patterns, okay? So in a regular rhythm, the time between each breath is fairly consistent, where in an irregular rhythm, there may be long pauses, maybe clusters of breaths, or just completely erratic pattern. Irregular rhythms can be signs of neurologic or metabolic issues, or they may indicate fatigue in patients who've been in distress for some time. Now, in our pediatric patients, irregular respirations can also occur just naturally during sleep or crying, so you have to use clinical context, all right, especially before treating. Now, a rhythm that starts regular but then begins to slow or becomes inconsistent, that's especially concerning because it often signals decompensation when we're talking about shock. So the goal is to really catch this early and respond before respiratory arrest actually occurs. Because it's important to remember that changes in breathing rhythm can be just as important as the patient's rate or depth of breathing. Now, how do we evaluate the quality of breathing, right? So normal breathing should be silent, effortless, and symmetrical, okay? So if you hear abnormal sounds like, wheezing, gurgling, stridor, crackles, you may be dealing with an obstruction, right? Or fluid in the lungs or a narrowed airway. You need to also watch for signs of labored breathing, such as the tripod positioning, accessory muscle use, 2 to 3 word dyspnea. These physical signs are going to tell you that the patient is working hard to breathe, and that's a warning sign. So in trauma patients, uneven chest rise really could indicate a pneumothorax or a flailed chest. So if breathing appears labored or abnormal, apply oxygen as appropriate, assist ventilations if necessary, and prepare for rapid transport. A patient may look okay one moment and then crash the next. So really constant reassessment is going to be key when respiratory quality is compromised. So now let's talk about the depth of breathing, or we're going to talk about tidal volume, okay? So tidal volume is the amount of air that's moved in and out of the lungs during each breath. Now, this is something that we would actually be able to diagnostically, clinically test in the hospital setting. But when we're in the pre-hospital setting, we can't really judge how much volume is being exhaled but with each breath, but we can identify the adequacy of the chest rise and fall. So when we're talking about tidal volume, that's typically what we're referring to. Okay, so normal breathing depth really should result in visible chest rise and fall without being overly shallow or exaggerated. Okay, now a shallow respiration may mean that the patient isn't moving enough air to effectively oxygenate their body. So even if the rate appears normal. Conversely, very deep breaths could actually indicate what we call metabolic acidosis, maybe anxiety, or maybe even a compensatory response to hypoxia. So it's important to really evaluate the rate, the rhythm, and depth all together to determine the overall respiratory adequacy, okay? So, because remember, someone who is breathing 20 times a minute but barely inflating their lungs still isn't ventilating well, okay? So you really want to watch for poor chest excursion and be prepared to assist with ventilations with a BVM, again, if indicated. Now, lastly, or almost lastly, but when it comes to auscultations, okay, that's going to be to listen. You'll want to listen to breath sounds in multiple lung fields, both anteriorly and posteriorly. Always compare both sides. You want to place the stethoscope firmly against the skin, not over clothing, and ask the patient to take a deep breath through their mouth. Okay, and then listen at the mid-clavicular line on the front, then along the mid-axillary line, and then finally on the back. And again, we talk about the more specific anatomical landmarks of where we want to be when we're auscultating the 3 different lung fields in lab. But yeah, so you want to for these breath sounds. They're going to be often clearer on the posterior side, especially in our pediatric or elderly patients. But you're really just listening for normal airflow, okay? And that's going to just sound like soft rustling sounds, as well as any abnormal sounds, okay? And then we're going to go over that next. But if you only hear sounds on one side or diminished sounds in a specific area, it actually may indicate like a hemothorax or a pneumothorax, or maybe just fluid buildup like a pulmonary edema. So your findings here should really directly inform your treatment and your treatment plan. So now, as promised, let's kind of break down the different types of abnormal breath sounds that you might hear. So you have snoring, okay? So snoring indicates an upper respiratory obstruction, and that's often from the tongue in our unresponsive patients, okay? We have wheezing. That's going to be a high-pitched, kind of a musical sound, usually heard on expiration, and that's associated with asthma or a bronchospasm. Then we have crackles or rails, and that is a wet, kind of like popping sound heard during inspiration, and it's often from fluid in the alveoli. So think of like congestive heart failure, pulmonary edema. Then we have rhonchi. So rhonchi is kind of like a coarse rattling sound that often clears with coughing, and that's going to suggest that like mucus or secretions are in the larger airways. Then we have stridor. Stridor is a loud, kind of high-pitched sound, and again, that's usually heard without a stethoscope, and that indicates a serious upper respiratory obstruction. So as an EMT, recognizing these sounds can really help you identify the underlying problem and whether it's like a mechanical situation, fluid-based, or inflammation-based. So if any of these are present, you're likely going to need to initiate some type of oxygen therapy, maybe reposition the airway, suction secretion, or escalate all the way to ALS for advanced airway management. Now let's move on to cardiovascular issues or the cardiovascular system. Now, if the patient complaint includes chest pain, dizziness, palpitation, syncope, or just signs of like poor perfusion, this is where your focus will be. Okay, you want to start by inspecting the chest for any types of trauma, listening to breath sounds. This is going to help differentiate a cardiac versus a respiratory origin. Then you're going to assess the pulse rate, rhythm, quality, evaluate skin signs, blood pressure. Now, in some patients, you actually may detect an irregular or absent pulses. You may see signs of shock or other symptoms that are really suggestive of a cardiac ischemia. Okay, so really pay attention to signs like diaphoresis, pale or mottled skin, or just delayed cap refill. These findings can really guide early treatment decisions and your transport priorities, okay? Because you got to remember, cardiac issues don't always present with textbook symptoms, especially in our elderly patients or our women. So keep a high index suspicion at all times. Now, as you're assessing the cardiovascular system, your findings will often start with the pulse and skin signs, okay? But again, they don't stop there. Take a moment to really evaluate the overall appearance of a perfusion, right? Is the patient pale? Are they sweaty? Are they anxious? Is their skin cool or mottled? You should also compare distal pulses on both sides of the body, particularly the radial, dorsalis pedis, posterior tib pulses, because unequal pulses can really suggest vascular compromise or shock, especially in our trauma patients. So in more advanced assessments, such as those done in ALS or hospital settings, auscultation of heart sounds may be performed to detect murmurs, gallops, or precardial rubs. Okay. Now, as an EMT, your responsibility is simply to recognize when the cardiovascular system is actually failing or is compensating and act to quickly support it. So let's kind of review normal pulse rates. So in a healthy adult, a resting pulse rate should range anywhere between 60 and 100 beats per minute. Now, it's important to keep in mind that and infants often have naturally higher pulse rates. But again, we're going to talk about more of that when we get to the pediatric chapter. And then athletes or just very fit individuals may actually have slightly lower rates. So when evaluating the pulse, note not just the rate, but also whether it's strong or weak, regular, irregular, and whether it matches the clinical picture. Okay. For example, you have a high pulse rate, so we call that tachycardia. In a trauma patient, that may indicate hypovolemia, while a slow pulse or bradycardia in a hypoxic patient may be a sign of impending deterioration. So always interpret the pulse in the context, okay? Use it alongside blood pressure, alongside mental status, and just other signs of perfusion to really assess the bigger picture of the person's cardiovascular system. Now, your pulse quality is going to tell you how well the heart is actually contracting and circulating blood. A bounding pulse feels unusually strong and actually may be seen in patients with, a fever, anxiety, high blood pressure, where a weak or a thready pulse is barely palpable, and that actually may indicate shock, blood loss, or some type of cardiac dysfunction. So you want to make sure to assess pulses bilaterally, both radial arteries or both pedal pulses, to evaluate for symmetry. Okay, an absent or a weak pulse on one side could suggest a vascular injury, maybe a blockage. But also check for central pulses like the carotid or femoral in your unresponsive patients, okay? Because these are going to be more reliable than the distal pulses when the perfusion is going to be critically low. And then again, like with everything, it's important to document your findings clearly, including whether the pulse was regular, irregular, or just absent. Now, when assessing the pulse rhythm, right, this is the timing between each beat, right? Is it regular or irregular? In a regular rhythm, each beat occurs kind of at a predictable interval. In an irregular rhythm, the beats actually may come early, may come late, or may actually skip altogether. And then some irregularities are actually benign, like occasional premature beats, but others, such as atrial fibrillation or bradyarrhythmias, they actually may indicate more of a serious cardiac issue. And if a patient's pulse rhythm is consistently irregular and they have signs of poor perfusion, such as dizziness, fatigue, or altered mental status, you really should consider them unstable and really prepare for immediate transport. Irregular rhythms may be difficult to detect with automated devices, so you really should always palpate manually and then trust your hands over the monitor when rhythms don't quite match the clinical presentation. Now let's move on to blood pressure, right? So blood pressure is a vital sign that's going to tell us about the force of circulating blood against the arterial walls, okay? Now, a BP is determined by several factors, right? The strength of the heart's contraction, the volume of blood in the system, and the tone of the actual blood vessels, okay? A drop in blood pressure actually may indicate blood or fluid loss, maybe poor cardiac function, or dilation of blood vessels due to sepsis, maybe neurogenic shock. On the other hand, a high blood pressure actually may suggest stress, pain, or an underlying condition like hypertension. But it's always important to remember that blood pressure is a late sign in trauma and shock. Okay, so by the time it actually drops, the body has already lost a significant amount of compensatory ability. So that's why you must always rely on other early signs like the skin condition, mental status, and the pulse to detect shock before the blood pressure bottoms out. Now, a blood pressure trend are often more valuable than just a single reading. For instance, a patient whose systolic blood pressure drops from 118 to 94 over 15 minutes may be a sign of progressive shock, even if the final number isn't critically low. That sudden drop in pressure or that widening gap between the systolic and diastolic numbers may indicate some type of internal bleed, maybe a cardiac tamponade. Conversely, very high pressures, especially those in like the 180 range for the systolic pressure, that could actually raise a significant concern for a possible stroke or an aortic dissection. So, really always interpret the blood pressure in the context of the patient's presentation and their chief complaint. Any reading that's abnormal for one patient actually might be normal for another. For example, so, some patients with chronic hypertension may not show symptoms until their pressure drops, well into that normal range. So what matters most is whether the patient is symptomatic or showing signs of poor perfusion. Now, there are two actual common methods to measure pressure. You have an auscultation, which uses the stethoscope and a sphygmomanometer to listen to the Korsakoff sounds, and is the most accurate method. Okay, then you have palpation. This involves inflating the cuff and feeling for the return of the radial pulse, which is only going to give you the systolic pressure. Okay. You'll record it as something like, palpated systolic of 100 millimeters mercury, or just written out as, 100 mmH over P. Palpation is useful when the environment is just like too noisy or if you're unable to locate the heart sounds. However, it does not provide a diastolic reading, so always note the method used in your documentation. Also be mindful of conditions that kind of influence where you place the cuff. For instance, you want to avoid arms with like dialysis fistulas or recent mastectomies or injuries to a specific arm. So when in doubt, though, you could use the opposite arm or the brachial artery in
or just the femoral artery in the leg, so if necessary. So the goal is always the same though. So you want to get the most accurate and relevant information to support your clinical decisions and treatment decisions. So as we conclude the cardiovascular assessment, remember that blood pressure should always be interpreted alongside the patient's overall condition. A single blood pressure reading doesn't give you the full story. So instead, you need to observe trends. Compare it with the mental status, the skin signs, and the pulse quality. Abnormal pressures, whether high or low, really should never be ignored, especially if accompanied by symptoms like dizziness, chest pain, altered consciousness, or syncope. Blood pressure really is not just a number, it's a reflection of the circulatory system's ability to maintain perfusion to vital organs. And as always, if something seems off, reassess and repeat the vitals, right? A patient's status can change rapidly, and your ongoing assessment is really the only way to catch it early. Now let's shift into the neurologic system, okay, which really plays a critical role in assessing patients with head injuries, stroke symptoms, syncopal episodes, dizziness, altered level of consciousness. A quick but really effective neurological exam includes checking the level of consciousness, checking orientation, speech, pupil response, and motor and sensory functions. You're going to build on what you learn in the primary assessment, but go deeper here, right? So, if the patient has had a possible head injury or a sudden change in behavior, you need to be thorough, okay? Ask if the patient knows their name, the date, where they are, what happened. These 4 orientation questions are going to help determine their cognitive status. And then again, always observe whether their speech is slurred or confused or delayed. Again, as these may indicate a stroke, intoxication, or just, again, some type of neurologic event. It's important to always be ready to reassess mental status throughout your care because it can really shift quickly and dramatically. Now, when you suspect a neurologic issue, a valuable tool is actually the Glasgow coma scale. Okay, so this scoring system is a patient's level of consciousness based on 3 areas. You have eyes, verbal, and motor. So their eye opening, verbal response, motor response. And these eye opening has a 1 to 4 point system, verbal 1 to 5, motor 1 to 6. The maximum score is a 15, and that means the patient's fully alert, whereas the minimum is a 3, which is deep unconsciousness. The GCS really helps you quantify the changes in the patient's mental status over time. Like, for example, a patient whose score drops from a 14 to a 10 en route to the hospital may be experiencing rising intracranial pressure or a worsening brain injury. So even if you don't use it, the GCS formally on every single call, understanding its structure is going to help you think through what you're seeing. Are they opening their eyes spontaneously? Are they speaking clearly? Can they follow commands, localize pain? These observations are going to be essential for trauma, for stroke, for altered mental status calls. Next, you need to assess the patient's pupils, okay, which gives you real-time feedback about brain function and perfusion. Pupils are controlled by cranial nerves and respond to changes in light and neurologic tone. So, in a healthy patient, the pupil should be equal, round, and reactive to light. And that's where we abbreviate as Pearl. Okay. So to assess this, you're going to shine a pen light into one eye at a time and watch for constriction of the illuminated pupil as well as the consensual response in the opposite pupil. If you have unequal pupils, which is called aniscoria, sluggish response or non-reactive, reactivity, that actually may indicate a trauma, maybe a stroke, hypoxia, increase in intracranial pressure, or possibly drug use. So really always document your findings, and if there are changes during care, you just have to reassess frequently. Because pupillary changes can be subtle, but are often the first signs of significant neurologic deterioration. Now let's look at some common abnormal pupil findings and what they actually indicate from the images provided. So you see we have constricted pupils, that also known as myotic pupils. These can be caused by opioid use, exposure to bright light, or certain neurological conditions. You have dilated pupils, which may result from shock, cardiac arrest, head injury, maybe a stimulant drug use. Then you have unequal pupils, and this can be a signal for increased intracranial pressure, a brain bleed, or direct trauma to the actual eye or optic nerve. So it's really important to know that some patients have naturally unequal pupils, and that condition is called anoscoria. So if the patient is alert and oriented with no neurological complaints, and they confirm that this is normal for them, it may not be a clinically significant sign. However, if anoscoria is new or accompanied by altered mental status, you have to assume it's pathological until proven otherwise. So you want to document all pupil assessments carefully, especially if you're seeing signs of deterioration or just asymmetry. Now, when the pupils show abnormalities, it's often a sign of a depressed brain function. This could be due to head trauma causing brain swelling or bleeding, stroke, especially if one side of the body or face is also affected, maybe hypoxia or poor perfusion of the brain, overdose or poisoning, especially if it's a CNS depressant. And then again, on more like rare cases, a brain tumor or a lesion. So in these cases, you may also observe changes in the patient's mental status, their speech, motor control, maybe their vital signs. This pupillary change are part of the overall neurologic picture, and it should never be viewed in isolation. Okay, so just include them in your reassessment because a declining brain function often shows up first in subtle changes like delayed pupil reaction or a sluggish speech. So really act fast if you suspect a neurologic emergency, because again, time is brain, honestly. Now, to summarize again, the mnemonic pearl, when you're assessing pupils, you have pupils equal and round, irregular in size, and reactive to light. If the pupils are not pearl, it could indicate, again, a serious neurologic example. You're going to use, again, we've already talked about this, but just to re-hit it home, you're going to use your pen light to check reactivity in both eyes. And again, you want to remember to check for that consensual response. So that means the opposite pupil should constrict as well when the other pupil is exposed to light. And again, take note of any eye trauma, contact lenses, artificial eyes, which can also impact your findings. Pupil checks are typically fast, easy, really informative. Okay, so especially when evaluating patient's conscious level, stroke, overdose, or trauma. You need to make pupil evaluation part of your initial and ongoing assessments, because it's going to be a small step with big implications. So now let's kind of go to our neurovascular status now. So this is going to be particularly important in patients with extremity trauma. This is where we're going to evaluate a patient's motor, sensory, and circulatory function, especially distal and distal to an injury. So you're going to ask the patient to move their fingers or toes, which is going to check that motor function. Then you want to assess sensation by gently touching their skin or asking if they can feel the light pressure or temperature changes. And then finally check circulatory status by feeling the distal pulses. And you really want to compare both sides of the body. So if there is swelling, deformity, loss of circulation that's distal to the injury site, it just may signal vascular compromise. Maybe even compartment syndrome or a nerve damage. So really this assessment should be repeated frequently, especially after splinting. Always compare one side to the other. You want to document thoroughly, and then early recognition of compromised neurovascular status can actually preserve a limb and save lives. So now, we start the physical exam of the body with the head. Again, we're jumping back and forth a little bit, but we're talking about anatomic regions. We're just going to go more into depth. So we start the physical exam of the body with the head, neck, cervical spine, areas that are really especially vulnerable to trauma. We're going to begin by palpating the scalp and skull, feeling for the deformities, those lacerations, swelling, fractures, looking for bleeding and bruising behind the ears, which we call battle signs, or around the eyes, which we call raccoon eyes. And these are both like classic indicators. Well, at least the raccoon eyes is a classic indicator of a basilar skull fracture. Then we're going to assess the eyes. Again, are they pearl? Are they symmetrical? Is there any bruising, redness, foreign material? Again, check the pupils again as part of your neurological assessment. Also observe the sclera, which is like the white parts of the eye, for signs of jaundice or trauma. Because trauma to this region often involves hidden injuries and it requires close attention to detail. So you really want to be slow but thorough. Then, as you continue your exam by inspecting and palpating the facial bones, you're gonna check the cheekbones, which we call the zygomatic arches or zygomatic bones, the jaw, which is the maxilla and the mandible for pain, instability, misalignment. Ask the patient to open and close their mouth, and if they're able to, that's going to assess the jaw function, right? You want to check for missing or damaged teeth, especially if there's any oral bleeding or airway compromise. Blood, broken teeth, or soft tissue swelling in the mouth can really become a serious airway obstruction. You also want to look in the ears, the nose for blood or cerebral spinal fluid. This cerebral spinal fluid is going to be kind of like a clear straw-colored fluid from either, which either may indicate like a skull fracture, and you have that CSF just leaking in those canals. To test for that, you're actually going to use something called the halo test, and that's when you're going to take a gauze pad or a 4x4, and you're going to place it up to the ear or nose where you see that fluid. And if there's a little bit of blood in there, you're going to have a blood dot surrounded by like a yellowish tinged ring, and that which looks like a halo, and that's positive for cerebral spinal fluid. So in short, right, these assessments are just critical for early recognition of any type of potential brain injury or airway compromise. Now, after the face, you're going to move down to the neck and the cervical spine. Always assume a spinal injury and trauma until it's ruled out. So you want to palpate the cervical spine gently, checking for tenderness, step-offs, deformities, any type of muscle spasms. Look for any visible signs of trauma like bruising or swelling. You're going to look at the trachea. It should be in the midline, because if it deviates, we're going to call that tracheal deviation, and that indicates a tension pneumothorax or some type of serious chest trauma. In the neck, you're also going to look for what we call jugular vein distension or JVD, and that's a sign of either increased intrathoracic pressure, heart failure, or maybe a cardiac tamponade. Regardless, you really want to be cautious not to manipulate the neck if you suspect a spinal injury. So if your patient hasn't already been immobilized, maintain manual cervical stabilization while completing the portion of the exam, and really prepare to apply a cervical collar as it's indicated. Then you're going to secure the airway, protect the spine, and that's really the priority in this specific region. Finally, it's important to inspect for medical alert tags, especially in the neck and wrist areas. These can provide really essential information about conditions like seizures, diabetes, allergies, maybe implanted devices. So if a patient is unresponsive, unable to communicate, just a quick scan for jewelry, wristbands, tattoos, medical alerts can guide your decision-making process. Always note that the presence of tracheostomy tubes, stoma, central lines in the neck or the upper chest as well. These may require like special handling and can always impact airway management. So as you complete the head and neck region, you should now have a real strong understanding of both the trauma risk and the clues for underlying medical conditions. So once that's done and the spinal precautions have been maintained, you're going to move on to examine the chest and the respiratory system in just greater detail. Okay, so now as we do move on to the actual chest, you want to start your inspection for looking for symmetry, visible trauma, paradoxical movements, or just signs of flail chest. Okay, so then you perform palpations, checking for pain, instability, crepitus, and these are all indications that at least the crepitus could be an indication that air actually might be leaking into the soft tissue, and we're going to call that subcutaneous emphysema. Yeah, you also want to listen closely to any abnormal breath sounds using a stethoscope, because if breath sounds are absent or diminished on one side, that's going to again potentially suggest a pneumothorax or a hemothorax or some other type of internal injury. Now, in our trauma cases, you want to apply high flow oxygen, monitor for signs of decompensation, and prepare for rapid transport. Any abnormal finding like chest wall instability, respiratory distress, that really should trigger an immediate reassessment of the airway and breathing status, because the chest is really where the life threats hide in plain sight. So it's important to stay alert to every single detail. Now, when assessing the pelvis and the abdomen, there are really two regions where hidden bleeding and organ damage can really rapidly lead to shock or death. So you want to begin with inspection, looking for bruising, distension, penetrating traumas, and then move to palpations, starting gently with the quadrants that are furthest away from the pain. You're going to feel for tenderness, rigidity, rebound tenderness, which can all suggest internal bleeding or peritonitis. Next, assess the pelvis by gently pressing inward and downward. It's important to not repeat this step if the patient actually has a complaint of pain, because again, just a single gentle check is more than enough. Any really pelvic instability may signal fractures, internal hemorrhage. So you never want to log roll a patient with a suspected pelvic fracture unless there's absolutely no other choice. It's more beneficial to use a scoop stretcher or a pelvic binder. The abdomen and pelvis really may appear normal externally, but again, it has the potential to conceal internal trauma. So you got to maintain that high index of suspicion. Now, like as you complete your secondary assessment, it's time to really record a full set of vital signs, okay? And this is going to give you a snapshot of the patient's current physiological status. This is going to include respiratory status, respiratory rate and quality, pulse rate, rhythm quality, skin color, temperature, moisture, pupils, blood pressure, SpO2, and potentially blood glucose levels, especially in our patients that are altered mental status, diabetic, or just have a suspected hypoglycemic event. Your vital signs are really your most useful when they're part of a trend, right? So don't just record them once. It's important to reassess regularly to spot deterioration or improvement, because small changes in your vital signs can reveal major shifts in the patient's condition before the symptoms are actually obvious. To go a little bit more deeper, let's kind of look at pulse oximetry. So this is a non-invasive tool that measures the percentage of hemoglobin that are actually saturated with oxygen inside the blood. A healthy reading is typically between 94 and 99%. Although there are lower thresholds that can be acceptable for patients with like chronic lung conditions like COPD. So keep in mind that your oximetry measures oxygenation, not ventilation. So a patient may have a good SpO2 reading and still have inadequate breathing or carbon dioxide retention. Also note that oximetry can be affected by cold extremities, nail polish, poor perfusion, carbon monoxide poisoning, which can give a falsely high reading. So again, use pulse oximetry as a supporting tool, not a replacement for your hands-on assessment. So if your patient has signs of hypoxia or respiratory distress, don't wait for the monitor, just treat based on your actual initial findings. Now, one of the most valuable but overlooked tools in your kit is the glucometer, right? And that's used to check blood glucose levels. So if your patient presents with altered mental status or a history of diabetes or just has symptoms like, dizziness, confusion, or weakness, it's important to actually check their blood glucose levels. Normal blood glucose levels typically range from 80 to 120. Really depends on your textbook. Some say 60 to 120, but 80 to 120 is, I think, what our textbook says. Though, again, slight variations may be acceptable based on local protocols. A reading below 70 really indicates hypoglycemia, which can mimic stroke, intoxication, maybe even a head injury. So if your system actually allows EMTs to administer oral glucose, do so promptly if the patient is conscious and can swallow. Blood sugar testing is relatively fast, easy, and it can easily prevent permanent brain injury if the hypoglycemia is caught early. But as always, you want to treat the patient, not just the number. So you really need to reassess frequently. Then once the baseline vitals are recorded, it's essential to recheck them regularly, okay? Especially if the patient is unstable or deteriorating. The general rule here is that reassess every 5 minutes for an unstable patient, reassess every 15 minutes for a stable patient. This really helps you spot those trends like a dropping blood pressure, rising respiratory rate, or a declining mental status. So before the situation becomes critical, and then reassessment isn't just about the vital signs, right? It includes like monitoring your interventions. Did the oxygen improve the patient's SpO2? Did glucose change their mental status? Did your tourniquet stop the bleeding? So these checks really inform your ongoing care and give the receiving facility a more complete picture of the patient progressions. Think of just like reassessment as a loop, like constantly checking back on everything you've already done. So now that we're like officially entering the final phase, the reassessment, right? So this is, like I just talked about, is your ongoing repeated evaluation of the patient throughout transport until you have the transference of care. The reassessment really includes 4 major components: rechecking vital signs, repeating your primary assessment, reevaluating interventions, and monitoring the chief complaint for changes. The reassessment really ensures that you don't miss anything, and it allows you to track deterioration, improvements, or just new symptoms. Because it's not uncommon for a patient's condition to change en route, even stable patients can easily crash. So your continuous observations and documentation really allows for early recognition and a timely response. So don't let the familiarity or a calming scene fool you into skipping the step, because really complacency is what kills. So you really need to stay vigilant. So it's important to start your reassessment by revisiting the primary assessment. Okay, are the ABCs still intact? Has the airway remained open? Is breathing adequate? Has circulation improved, remained the same, or deteriorated? If your patient is no longer alert or begins to show signs of shock, you really must return to immediate interventions, right? Suction, airway, reposition the head, oxygen therapy, bleeding control, assist ventilations. Your reassessment must also include a recheck of all life-saving devices and interventions. Is the oxygen mask still secure? is the tourniquet still in place, and is bleeding controlled? Are you seeing results from any treatment you've already administered? This is your time to really catch these complications early, especially in long transports or just with patients whose conditions are just evolving rapidly. Now, the reassessment phase is also when you evaluate the effectiveness of your interventions, right? So, if you started oxygen, has the patient's SpO2 improved? If you applied a tourniquet, is the bleeding controlled? If you gave oral glucose, is their mental status improving? These are the outcomes that you're checking for, not just to satisfy a checklist, but to ensure that the patient is moving in the right direction. If your interventions are ineffective, you just have to escalate the care. If the patient is deteriorating, you evaluate the ABCs and prepare for rapid transport or an ALS intercept. Don't just assume that the patient is stable because they haven't complained. You need to observe, reassess, and anticipate. These ongoing checks give you the best chance at preventing really avoidable complications and delivering the patient in better condition than you found them. Now, finally, we've reached the end, right? So at the end of it, you need to document every step of your reassessment. If you reassess vitals and nothing has changed, you just document that. If the patient's condition worsens or improves, you document that too. Include what time your reassessment was done, what changes you observed, and how the patient responded to treatment. Okay, this information really becomes part of the continuity of care and helps emergency department providers understand what's happened since you arrived. Okay, remember that EMS reports often become part of your legal medical record. So the more accurate and the detailed your documentation, the better support it provides. Not only for patient care, but also for your protection and professional accountability. Because reassessment, again, isn't optional. It's really a critical component of a complete pre-hospital care. So that's going to bring us to the end of our chapter on patient assessment. Again, there's a lot of content here, but remember, your patient assessment is just a structured, systematic approach. It's a conversation with the patient to uncover all the possible information you can need to make sound clinical decisions with sound judgment. So it's not something that you're going to learn overnight. It takes tons of practice. It takes tons of work in the lab, and it just takes experience. So keep working at it, and you're going to become proficient at it with time. Okay. So that does it for this chapter. I hope you enjoyed, and I will see you next time.